Good afternoon, everybody. Welcome to the November meeting of the Health and Wellbeing Board. I think that today I'm going to do some introductions, if you don't mind, at the beginning. So I'll just go quickly round when I finish speaking, because I'm very pleased to say that we've got our new Vice Chairperson, Jonathan Wade, who's the Interim Chief Executive from Medway NHS Foundation Hospital. So welcome, Jonathan. Thank you for taking on the role. And if we start introductions with you, Scott, and go around the table quickly, please.
Thank you. Scott Elliott, Head of Health and Wellbeing, Medway Council Public Health Team.
Hi everyone, my name's Sophie. I'm Senior Project Officer within the Kent and Medway Suicide Prevention Programme.
Hi everyone, I'm Ed Waller. I'm the Chief Strategy Officer and the Chief Commissioning Officer at the ICB for the NHS.
Good afternoon, everyone. I'm Suk Singh. I'm Director of Primary and Community Care at the ICB for the NHS.
Afternoon. Andrew Lawrence. I'm the Conservative member on the panel, and I am the member for Hempstead and Wigmore.
Mark Jones. I'm the member for Strood West, Labour and Co-op Group.
Afternoon, everyone. Chris Ford, Senior Public Health Manager in the Public Health Team, looking after physical activity programmes.
Afternoon all, James Sutton, Medway Council Sustainable Transport Manager.
Afternoon, Darren Taylor, Sustainable Transport Team, Medway Council.
Good afternoon, I'm ADP Member for Wayfield and Weeswood for Labour and Cooperative Group and the Group Whip. Thank you.
Hi, Simon Curry, Member in Luton in Chatham and also the Council's portfolio holder on climate and strategic regeneration, which covers transport, planning and all sorts of other bits and pieces like that. Thank you.
Hello, I'm Adrian. I'm with Health Watch Medway. I'm the Engagements Officer.
Good afternoon. I'm Louise Parker, Director of Strategy for Medway Community Healthcare.
Good afternoon. I'm Anna Batty. I'm the Business Manager for the Medway Safeguarding Children Partnership.
Hello everybody, I'm Stephanie Davies, Democratic Services Officer.
Theresa Murray, I'm the Chair and the Deputy Leader of the Council and the Portfolio Holder for Health and Adult Services.
David Whiting, Director of Public Health.
Hi everyone, Leanne Farrick, Director of People and Deputy Chief Exec, Medway Council.
Thank you, everybody. And we've got quite a few new people new to the board today. So, Jonathan, for your interest, I hope, what we try to do on the Health and Wellbeing Board, apart from monitoring how we're doing in terms of health inequality and taking a themed approach to elements of our joint health and wellbeing strategy in terms of monitoring, we also take subjects and ideas and new things that can contribute to health and wellbeing in Medway. So we've moved away from a sort of quasi-scrutiny role and we have a collective approach to what can everybody around the table contribute to the issues that we're looking at. And on that, I would like to say we have got an item on suicide prevention today. That is an extremely sensitive subject, and if you feel that you need to take a moment at any time that we're discussing it, please do so. You're very welcome, and we understand that for many people, and that's the reason for us really paying attention to suicide prevention, families, friends, people's lives can be touched by the tragedy of someone taking their own life, and I don't want anybody to feel that they can't step away if they need to. Okay, thank you. So we'll come to apologies. We've got apologies from Martin Riley from MCH, and we've got a representative. So Louise is here to help us, and also from Adrian Richardson, and I've got apologies from Councillor Tracy Coombs, who is unwell today. Any other apologies, please?
Kelly Cogger and Celia Buxton as well, so give their apologies.
Thank you, but we've got Leanne Farrick here, so, and I don't know if we've got apologies from Jackie, have we, Leanne, as well? Yeah, okay, thank you. So if we can record apologies from Jackie Brown. So I'll go now to the record of the meeting, which was held on the 4th of September. Our theme was Safe and Connected Sustainable Places, and we were very pleased to have the police here who talked about serious violence and about deaths from traffic. And it was really welcome to see that children's services particularly are working very closely with the police. After that, we had our climate change action plan, a big and important item that links actually today with what we're talking about on active travel. We had the pharmaceutical needs assessment, which was completed during the year. That's been a bit controversial in some ways, and we've taken it back to scrutiny. Then we went on to the work programme. Has anyone got any matters arising from the minutes or any corrections? Okay, thank you. Everybody happy to accept that as a record of the meeting on the 4th of September? Thank you. Are there any urgent matters from anybody? I have none. Any declarations of pecuniary interest and other significant interest, please? Jonathan.
Thank you, Chair. I just thought I should also point out that I'm the Permanent Chief Executive at Dartford and Gravesham NHS Trust as well, just in case anything ever crosses over.
Thank you very much. Okay, so we'll move to the first item, active travel in Medway, and we've got James, Darren and Chris to help us with this item. We're being asked to note the progress, we're being asked to support continued cross-sector collaboration, encourage partners, and think about today how we can identify opportunities to bring resources together for our active travel strategy. And of course, it's really important to remember that active travel contributes greatly to the health and well-being of our local population. So I don't know who's going to lead, but I'll pass over to you. Thank you, James.
Thank you, Chair. I'm very happy to introduce this active travel item this afternoon, and I'll just open it with a few words. So Medway's walking and cycling rates remain below national averages. Only 0.7% of trips to work are by bike, and for journeys under 5 kilometres, cycling is just 2.3%, while driving dominates at 57%. Walking accounts for 23.9%. These short trips could easily be walked or cycled. Increase in active travel journeys for whatever purpose is a transport, climate and health ambition. Regular physical activity can reduce heart disease by 35% and early death by 30%, while improving mental well-being. Transport contributes to 31% of Medway's greenhouse gas emissions, so change is essential. Our local cycling and walking infrastructure plan, or LCWIP as it's referred to, was approved by Cabinet in March of this year and sets out a 10-year strategy for safer, more attractive walking and cycling routes, informed by consultation with over 350 residents. It has and will continue to help us secure external funding and embed active travel in planning. While steady progress is being made, for example, school streets now operate at 12 schools across Medway and infrastructure improvements continue, there is a long journey ahead. Nationally, 43% of adults walk for travel 3 times per week. However, Medway falls below this. Our active travel group, made up of cross-party members and officers, ensures active travel is integrated across our work streams and strategies and monitored collaboratively. We ask the board to note the report and consider how partners can help by promoting active travel, aligning initiatives with our transport, climate and health priorities, and supporting community engagement. Active travel is a shared responsibility. By making walking and cycling a natural choice for short journeys, we can deliver a healthier and greener Medway. Thank you, Chair.
Thank you very much, James. Before I bring in Chris and Darren to give you an opportunity to say anything that you'd like to that gives us an insight into why we still haven't got as many people as we hope walking and cycling, I would like to offer the board's congratulations to the schools who have taken part. We've got 22 schools in the Big Walk and Wheel 2025, which is very positive. And I know that means that a lot of effort comes from teachers and from parents to make that happen. And I think for our teams, delivering 7 school streets is very welcome. And I know that for most of those, and particularly Greenvale School, where there's been a really fantastic response to children walking to school in one of our most challenged areas as far as health is concerned, I think that we should record that effort and congratulate people. So, Darren, would you like to add anything to what James said?
Yeah, I just want to say we've had really good uptake of all our initiatives and competitions throughout the year. The most recent one was Walk to School Month in October. I think we had about 20 plus schools sign up for that. And we have our own little competitions for primary and secondary schools called Striders for secondary schools and Little Trekkers for the primary schools. And in fact, tomorrow, is it tomorrow? Yeah, me and Jenna, I work with, are going to Twiddle Primary to present them with a certificate for coming top of the Little Trekkers. We're also going to Greenvale School, where in October, they came 5th in the whole country for active travel. It's called WOW, Walk Once a Week competition. It's just, and they get little badges and things, whatever. So Vince Maple's joining us for that to do the presentation. It's all very positive. Walking buses, we're really pushing that as well these days. Since the pandemic, it's kind of really tailed off, but we've got a lot of good resources now for schools. Me and Jen have done a couple of site audits for the routes and stuff recently, so that's on the move again. And also Mode Shift, which help people with travel plans, developing, updating, whatever. We've got 14 schools now signed up for that, and we had 3 at the beginning of the year, so it's all going in the right direction.
No, I think that's really good news, and it's important for us to remember actually that the kind of well-being of people who live near to schools is improved if fewer people take cars. Certainly continuing one of my biggest caseloads, having 2 grammar schools near to each other, and obviously I do accept that, you know, children who go to grammar school often travel further than children who are able to go to a local school, but for residents, particularly with inconsiderate parking and people blocking them in and all those kinds of things, that, you know, it's avoidable stress if we can work together on this. Chris, would you like to add anything?
Yes, thank you, Chair. Yeah, just really to commend the collaborative working approach that we're taking to active travel. The meetings that James heads up have been really fruitful, and it all helps towards some of our aims and objectives in public health. So we've got some specific targets in the 5-year childhood obesity plan related to active travel. So very important that we try and work on those. We want to increase the amount of kids travelling to school by active travel means by 5%. So that's really important to us in public health. We've also been supported by James and the team to develop some digital resources that might support people to become more active in the way that they travel. So I'd encourage people to look at the Explore Medway website. I'm rocking the brand on my T-shirt here. It's a great resource, and it's got a route planner on it, so if we can actually make sure that if someone does want to try an active travel means instead of taking single-use car, then we're giving them resources to be able to plan that, and it's got some really great advice on there about how you can take active travel means and gives you health benefits for doing so, as well as the reduction to CO2 from not using your car. So encourage people to promote that on our behalf, please, yeah, it's good to be here talking about active travel with you all today.
Thank you, Chris. And I think it's important to remember that we have got a lovely paper map available, haven't we? If anybody doesn't want to use digital, and they can carry that with them when they go on all of those walks. So before I open it to the rest of the meeting, I hope that people can see an awful lot is going on in Medway. The active travel group of members meets very regularly, and we're working across the council with friends in highways and transport, with public health, to really try to tackle some of these issues. So the first speaker I've got is Mark Jones, please.
Yeah, thank you very much, Chair. I'm impressed to see the amount of activity going on, particularly around schools, and particularly looking inwards on Medway Council to many of our departments and our own employees. I wondered if we could have a little bit more of a flavour of the sort of looking outwards of Medway as the local authority. I often ask at these meetings about the private sector. Are we encouraging other employers to have cycling schemes and parking and that sort of thing? Very often with issues like walking and exercise, the common refrain of people is we don't have time. You know, we've got to get from A to B quickly by car. So, you know, what are we doing to encourage things like flexible working, not only within Medway, but in the wider community, you know, to encourage people to walk to work and those sort of things. Thank you.
Thank you, Mark. Before I come to officers, we did recently have a really well-attended breakfast meeting to launch the Healthy Workplace strategy. And lots of the employers there spoke about the things that they're doing, including offering bike schemes through salary sacrifice and other things. And I think there was high recognition, actually, from that group that it can contribute to well-being. And also, when people have got a town centre business, one of the things that the people who attended said was that parking's a bit of a problem anyway, so the more they can encourage people to use public transport, walk or cycle, or even a combination, they were keen to do it. So I think that's on the money, Mark. Officers, would you like to add anything to Councillor Jones, please?
Thank you, Chair. I would just add that a lot of our work within transport is engaging with schools, as you've rightly noted. But we signed up to something called Mode Shift. It's a national platform, and it really encourages travel planning not only for schools, but for workplaces and other businesses and the like. Residential, there's different forms of travel plan that we're really trying to encourage. I think it's right, as a council, we are setting an example. We're currently using Mode Shift to create a staff travel plan and really encourage other businesses to follow suit. It'll be looking at measurable actions, achievable targets, hopefully, and just, that collaborative working with one another. So, certainly an area we want to get more involved with in terms of business engagement, and I know a lot of good work goes on in public health as well. Things like workplace health challenges and the like, to encourage people out of the cars, particularly, as I say, for the shorter journeys. Many of them are walkable or by bike. So, thank you.
I think before I come to you, Councillor Lawrence, we'll have as an action a message to the friends and colleagues in economic development to ask them whether they're able to shine a light on some of this and share some of the good practice. So I've got Andrew next and then Leanne, please.
Thank you, Chair. I think it's about the third time I've read this report at different committees, so it's good to see the updates. I think just as a general comment, I think if we want individuals to be accountable for their own health, then encouraging walking is definitely one of those things that we should be doing. I was just, in terms of all the activity, how are we making sure that a change in behaviour for a short period then becomes embedded? So we run a campaign at primary school level. How do we make sure that that actually has effect over a longer term when children go into senior school and then they go into further education? What is that strategy looking like? Just in terms of targets, have we set ourselves any targets for increasing the number of adults who are walking more than, is it 3 times a week is and what that target looks like and how we're measuring that? It'd be interesting to get a general measure on, general idea of how you're measuring all of this doing. And just finally, I was just interested in terms of improving the walking environment, how much money have we actually physically got for that? How much is in the budget? How much of it's committed? What projects and plans are actually ready to go? Thank you, Chair.
I think it makes sense to answer the questions as we go along, actually, because that was quite a long one. Thank you.
Thank you, Chair, and thank you for your questions, Councillor Lawrence. In terms of ensuring that the change is embedded, it's a case of establishing longer-term relationships with the schools, so working through all age groups and indeed transition when those primary schools transition to secondary schools, following suit. So there's a consistency with the initiatives that we're offering and through the travel plan. And we have a number of teams within not only our service but other partners as well that we kind of work with schools differently, from a different angle, if you like. So we've got our active travel team led by Darren that will promote the walking to school and the cycling initiatives. And then we have others that go in from more of a safety perspective, so promoting road safety education and the like. But yeah, very important that we do continue that ongoing relationship with the schools. And there's different ways of engaging as well. Some schools prefer to take part in the one-off initiatives, and that's fine. But there's always the hope and the will, certainly from us, that they will continue those good habits, longer term. In terms of the targets, that's something. We've got an active travel group coming up in a few weeks' time in mid-December, and the adult health 3 times a week for active travel is something I'm very keen to take through our active travel group and be measuring consistently as well. So we currently have a number of cycle counters across Medway, and we monitor that closely. I think we need to be doing more in terms of adult-led health. We do a lot, as I say, with schools as well, but that's something I'd like to take through the active travel group. And in terms of the funding, yep, you're quite right to ask that. We've been very fortunate in that we've received funding allocations through Active Travel England and have done each year, both capital and revenue allocations. Up until this year, they used to be separate. We'd receive a separate capability fund, Active Travel revenue allocation, and the capital allocation, as I say, would be separate. So in terms of how that funding's used, the first instalment we had from Active Travel England was way back in 2020-21, and that was termed an emergency active travel fund, and we were able to use that in terms of pedestrian accessibility works, improving cycle and walking infrastructure across their towns.
Cycle storage.
Yeah, I know Darren very much led on that. And then we had a second tranche, Active Travel Fund 2, we used in line with our Four Elms Hill schemes. We did a shared footway, cycleway there on both sides of the carriageway. So that funding was invested towards those particular schemes. We then had another capital allocation, Active Travel Fund Tranche 4. That was 486,000 in total. We used towards our school streets delivery in Medway, and that's ongoing, as I say. We launched 7 sites last year. We've launched a further 5 under the second tranche this year. Active Travel Fund Tranche 5 we received last year, and we're using that to develop our LC-WIP, the walking and cycling strategy. From that, we had a number of high-level concepts. We're using that Tranche 5 of the Active Travel Fund to develop those conceptual designs into more detailed scheme designs with the intention to go out to consultation next year. And then this year's consolidated Active Travel Fund, 568,000, we're using to deliver on those schemes. So once we've got the detailed designs in place, the intention is to be able to deliver on a number of those. So, and then revenue funding's been used slightly separately in terms of initiatives and the like. So, yeah, thank you,
Before
Chair.
you come back, Councillor Lawrence, Councillor Curry's got some additional information he'd like to share, so I'm going to allow him to come in. Thank you.
Apologies, Chair. I was implying, if I could come in right at the end of the last comments gone through, and I'll just come in at the end of those.
Oh, I see, that's fine.
Yeah, thank you.
Sorry, I thought you were... Carry on, Andrew.
Thank you, Chair. Is there any chance you could write back to the committee once that target has been set for adults walking? I'd be interested to see how some of our health partners might be able to get that into their practice in terms of encouraging walking. I think you're right, it's good for mental health, it's good for physical well-being as well. And just a comment on the school street scheme. The school street scheme certainly works at some schools. Schools in my ward, Fairview Primary School, we've managed to box in a whole load of elderly residents who now can't get to care appointments and things like that. And what's really disappointing is having written on this is that I'm just getting the computer says no, and no one seems to be interested about elderly residents, and I think you'll know the roads that I'm talking about, who are literally having to miss appointments because it's not a regular carer that takes them to those appointments. So there are consequences. And also, of course, we've had to write off £1 million worth of fines because we've not been able to collect them on the school street schemes as well. Thank you.
Yeah, just before you come back, I think, actually, I'm in part in agreement. We've always said that there might need to be refinements, and I do think the situation with carers making early morning calls is something that we need to tackle. At the moment, what happens is that a penalty is issued and then obviously it is disregarded, but preventing it from being issued, if someone is in that situation, I do think we need to look at that because it's certainly something that's been drawn to my attention, both from residents and actually from employees at the council themselves. So I'm not expecting you to answer that now. Councillor Curry's here and he's going to come in at the end, but for your comfort, Councillor Lawrence, that is on everybody's radar. So it's not so much telling you that the computer says no, although it does. It is being worked on. Okay, we need to make the technology work in our favour. So I'll go to Leanne now, then I've got Eddie and then Jonathan and then Adam after that. Okay.
Thanks, Chair. And it's really good to see in this report that the type of infrastructure that we're working on in Medway. You know, on the whole, the majority of young will be active. They will walk, they will move, they'll play sport, etc., etc. So we're kind of pushing against an open door there. I want to talk about what happens in the span of life when you move away from being young and you move into the frail and less mobile cohort of Medway residents. I've spoken to some of them and talked about you know, their ability to enjoy some of this infrastructure, to enjoy some of the great opportunities Medway has around walking. And one of the things they say to me, and it's really counterintuitive to what's in here, is they need more seats, because they won't embark on the walks because they don't want to get halfway there and either fall over and end up in in the acute trust or whatever else. So they need more seats so they can actually enjoy some of this, but sit down when they need to sit down, keeping them mobile, keeping them active, keeping them, you know, that whole frailty and falls is just a tremendous risk for some of our elderly residents. So I just wondered how you're dealing with that, because I think to focus on just the young, just the active, just the is something that we need to move away from a little bit, because you know, I'm sure John would vouch for me in terms of frail elderly and what happens to them when they end up in the acute trust. So thank you, Chair. Chris?
Thank you, Chair. Yes, so in public health we have a falls prevention service called FAME. You'll start to notice it all around the area. Some really nice purple branding that can't be missed, and that is hoping to tackle some of the situations that we find ourselves with in terms of falls in Medway. So it focuses on the early stages of frailty, looking at people on the early points in the scale when it comes to falls prevention, trying to prevent falls in the first place. We've got 8 sessions now going on all around Medway, which are all full up, and dovetails perfectly with the Medway Community Healthcare Falls Prevention Service as a real pathway. We don't just let people go at the end of that programme as well. We make sure that they go out into community sessions, short walks in parks that we run called Walk in the Park, or other community settings that are delivering seated exercise if that's appropriate. But certainly as a public health team, we've noted the need for that service from the Better Care Fund, put that in place, and that's now a really brilliant service that's up and running and helping people to prevent them from falling in the first place.
Thank you, Chris. I mean, I'll come to you, Scott. I think we do, and all of those for the board, those activities are free, and people can self-refer or be referred, and they are very popular. On the general issue of seats, Leanne, we've got a bit of a dilemma here, because of course we have taken some seats out, for example, in Chatham, because they were the focus of antisocial behaviour. But the Chatham Design Code that we're bringing forward, and there will be other design codes for other town centres, does allow for stop and rest, stop and play parts of the design. And, you know, we've worked with the police to try and get on top of antisocial behaviour, and that was one of the things that they suggested. But there are, and the paddock is a really good example of this in Chatham, there are types of seats which are built to resist vandalism and other forms of antisocial behaviour. So I think what we're hoping to do is refresh and modernise the type of seating. But it's important to mention it, and for the board, on the 5th of December, I'm bringing together a number of organisations in Medway who work with older people and some older people themselves to start the process for an age-friendly Medway, just as we have child-friendly Medway. This was, I think, 2 years ago, and we're a suggestion that Leanne very sensibly made to me. And it's something that needs doing. We do need to get that voice out there. And I think, Chris, on the walks that you go, which I've been very pleased to join, the fact that their supervisor is someone to encourage and make people feel safe makes a huge difference. And the walks that you design actually mean that the way they're configured, you know, that the people don't really need to have a stop, because they can do it, you know, very often our public health walks have got a short route and a long route, and the two routes meet in the middle, and we've got the colleagues there to help and encourage people and talk about safe footwear and other things that people can take. But we can do better, I think, in the urban areas with walking, so we'll take that, I think, seating issue away. So, Scott, you want to come in on this?
Yeah, I was going to mention design codes actually, and that central conflict of other well-intending competing initiatives. You know, another competing initiative, particularly affecting more older people, will be around the intention to make an area so inclusive, dementia-friendly, but actually a lot of the kind of shared pathway bits can lead to some people feeling like, actually, this is really complicated for me to kind of navigate. I'm not now clear where the lines are. So as part of the local plan bit, around the design codes, we have a public health planning officer now. So again, it's about thinking about all those multiple things, thinking about what's the best scenario, because Rainham is different to Twiddle, which is different to Chatham Centre as well. So yeah, that's something we can definitely think about, and finding the lesser of the evils as opposed to the perfect solution.
That's really good news. Eddie, please.
Thank you, Chair, for responding to Leanne about the seats. I did wonder if it was my imagination that there seem to be less seats around than there used to be, so thank you for that. Can I also say thank you to the authors of the report. I'm always so pleased to have an easy-to-read report, so just thank you for that alone, as well as the content. And Councillor Lawrence got there first. I want to endorse most of what he just said. Yes, every individual has responsibility to themselves, full stop, whatever it is, but that does include your mental and your physical well-being. That's always got to be the starting point, and then you go from there. But I do believe a lot of that is down to what you was basically taught by your parents. So I also believe parents and the act of parenting is also key to this and something to be encouraged. So, for instance, when I was a teenager, I took an hour to walk and get a bus to school. I don't think it would have ever entered my parents' mind the idea of driving me or picking me up, my responsibility to get from A to B, whatever I did. There seems to have been a culture change. I'm not even quite sure when, how, or why, but now it's like the norm that people drive, most probably on occasions when they really don't need to, and then clogging up, and you've got all these issues around schools. So I lead on to the question. I'm glad to see that there's been an increase of take-up, and also that the October walk to school was very successful. But what opportunity do you get, not just to talk to the children, the teachers, but also to their parents and have that discussion about their well-being, and all the way through the year, as Councillor Lawrence says, that's what really matters, is a habit forming throughout their lives, in fact. Thank you.
Thank you, Councillor Peake, and through you, Chair. I think you raise a really good and important point around the importance of parenting. I know with a lot of the initiatives we promote through schools, it's not just focused on the children, but indeed the parents as well. It's important that they set really good habits, and that often follows through as the young children kind of get older. So we encourage a lot of that through the school travel initiatives that we do promote, trying to encourage everyone, the wider school community, and not just the children. The children are extremely important and very much at the forefront. And I know when we used to promote like the walking buses, we would be reliant on the children, the pester power. You know, quite often the children could influence the parents. Oh, go on then, let's walk today then. And that's what we find. The children want to walk. There is that will from them. Quite often it's trying to encourage the parents to, come on, let's just give it a go. And hopefully that behaviour will continue. I think you raise another good point around the cultural habits as well. They ideally need to change. People get set in their ways. They think for those short trips, it's easier that I jump in the car. Quite often it isn't. Those short trips can be walked or cycled faster than by car. So I think it's important to recognise that. It's breaking the routine as well. You know, it's trying to break that whilst appreciating the other factors that come into play. as well. And then safety can come into it, and yeah, just people's lifestyles and the like. It's just making active travel more of an attractive option for the majority, which takes time. It's not something that happens immediately. That cultural change and other measures that we're working on all take time, but there's very much the will to be working with their communities, be it children, parents, or the like. I would say within transport, we do when we go into schools. So quite often we will focus their discussions to parents as well as the children. We could do more of it though, I recognise that. So a lot of it, you know, we deliver education and initiatives that are targeted to the children, but it's to encourage the parents as well. So there are occasions where they come in and we will talk to them, but I think we could do more of that. Yeah, thank you.
Yeah, I mean, thanks, Eddie. And I think perhaps as an action, let's talk to colleagues who are working directly with schools about perhaps having events or including active travel when, for example, there's a parents' evening. I know that that was done at the 100 of Who School to encourage walking and cycling. So we'll think if we can, how we can work with colleagues to do more of that. Thank you. Jonathan, please.
Thank you, Chair. It was just to say I think there's a real opportunity to work together on this with the hospital, obviously, with 5,500 employees. I'd really like to work with you on this and see how we can take it forwards.
Is Chris?
Yeah, just on that. So there was a new bike shed put into the hospital recently. We've done some good work with colleagues at the hospital to following your active travel survey, just to try and find out how many staff are using active travel means to go to the hospital. And so there's already the doors open to more of that. We've got something what we call Dr. Bike, who we can bring in to help people with their cycles, some basic repairs and education. So moves are afoot to try and work with, particularly with larger employers. You take part in the Workplace Health Award with ourselves, and we value that. And obviously, it's an opportunity to work with you guys. And yeah, that's been pretty successful so far, and we'll continue to do that.
Thank you. Adam, please.
Yeah, thank you. Mention was made of about design codes, and the Chatham design code, I think, came from, wasn't it Luton that had an area-wide plan that they were going to be doing? So maybe part of what we should be doing is encouraging more of these local plans for each area and using the kind of template of that design code, which could include features like active travel within areas. So you could design certain things in that's going to build up towards a more healthy-like community. Then the other thing that I wanted to mention is that going back into the early days of the Medway Health Champions, I remember Public Health dished out pedometers. Do you remember when that happened? I don't know anybody who was on the council then at the time or was in the scheme. And I was wondering whether there was any facts and figures that came out from that time when we actually had that, because that was quite like competitive then about how many steps people were making. Of course, I know that that's been superseded now because virtually everybody's got a watch or a mobile phone that's got the rings on there. But maybe we could promote more of the use of buddies. So when you're doing your exercise, you could be in tune with the friends and just compare how many more steps that you've done each week. That might be a way of running it forward. And then I wanted to make a plea, or a plug rather, for that we've got a number of obviously parks, including within my own ward, Gillingham North Ward. So we've got the Lower Lines Park, and we've got Hillyfields, and then of course we've got the massive walkway from Gillingham down to Chatham over the lines, etc. And maybe we could put a plug in for the green link that's been talked about many times to link Victory Pier up to Gillingham High Street, because we've got a massive growth in the number of flats and residents living down there who need the encouragement to be able to walk up a more greener route in order to get to the station in Gillingham High Street as well. I know that we spoke about this just the other evening within our informal cabinet when we were looking at the Gillingham High Street about measures that could make a startling difference if we were just able to put our minds to it. So I think that's it. And then just the other thing which occurred to me, we were talking about some seats being taken out of areas. I remember it wasn't that long ago whereby we used to have that chatty bench that used to come round and it was plonked down for a while and then taken away again. Maybe that's the way of being able to have like a pop-up seat, etc., which what that does is it encourages some of the more frailer folk to sit on the bench, but then to talk with people in the community going by in the high street. And then, of course, at the end of the day, the bench is taken away again, which overcomes the point that you were saying about undesirable use of benches. So that's, I'm just trying to think laterally and sort of like creatively about how we could, you know, get to the same end, but in maybe different ways because of, I think the times are changing. Thank you.
Thank you, Adam. I think that's really important. And I think you've done yourself a disservice not giving a plug for the Medway Ramblers. Adam's a very keen walker and Medway Rambler walk lead. So he's doing his part, absolutely, towards this. And yeah, I think the, you know, chatty bench, we shouldn't discount ideas. I don't know whether you have got any data, anybody, that Adam's asked for. It might be a while ago now, but I'm interested to hear from you, Scott.
Unverified, but it says Councillor Adam Price really high up, so, you know, you're doing all right. I'll dig it out.
Thank you. Thank you, everybody. So some really useful ideas and comments there for the team to take away, and some actions for us to join up around the council. I think before I come to Simon, you know, one of the things I'm very aware of is that the state of the roads contributes, and pavements contributes to people not wanting to walk and cycle. And so our strategy to do those bigger, longer lasting repairs has got its feet in improving well-being as well, because I think apart from anything, the look of some of our roads, particularly the back roads, put people off having a walk, and you know, I do want the board to know that the council is very mindful of that, and continuing to do the best we can to tackle those things. Simon, please, to finish the item.
Yeah, thanks so much, Teresa. And thank you, everyone, especially the team, for coming along today, and thanks, everyone, for their comments. I mean, this is a subject I could talk about all afternoon, so please put a line on it if I go on too long. I'm afraid I'm quite passionate about this. One of the things, I can't remember whether it was Scott or Chris has mentioned, or maybe both of them has at some point, a large part of their job is simply getting people off their backsides. And I think that's very true. It's about getting people active again and making sure that they're actually moving around a lot more for their health and well-being, but for a whole host of other reasons too. I think, and I just wanted to mention at the start as well, the Task and Finish group that we had producing a report recently on air pollution, which was a really amazing piece of work, and covered a lot of the ground that we're trying to cover in terms of the impact that traffic has on our lung health and such like as well. So there's all sorts of issues tied up in this active travel subject, if you like. And again, thanks to the team for the work that they're doing on this. It's the importance, and I like using the word decongestion because it has a sort of health implication as well, but we're decongesting the roads. Congestion is a serious problem in Medway, has been for decades, and the work that's going to take to decongest our road networks is going to not be done overnight. It's going to take time and requires a number of different initiatives, active travel being a key one in the heart of that, but we've mentioned planning and other issues as well. There is the issue around the use of public transport as well, and what we've done with the Active Travel Group, which is a cross-party officer and members group that meets on a regular basis throughout the year, is to look at the role of buses, and we've extended the terms of reference for the Active Travel Group to cover buses as well, simply because of the role that they play in there, and raising the bus journey numbers. I think we're on, is it 7.8 million journeys this year we've had, and we're looking to raise it to 9 million a year in about 2028. It's a very ambitious target, but it'd be fantastic, because the more people on buses, the fewer cars there are on the road. It's just a simple bit of maths, that. So I just want to pick up on a couple of points that were made earlier. You talked about that link to business, and that's very much in our minds, and that's why the active travel, the work of the team, is cross-cutting, if you like, with a lot of other things. We had a really good green business event earlier this year, and the team were there promoting that and encouraging local companies to adopt green activities, including that travel to work program and stuff like that. We also have a green grants program, and each of the companies that receives a grant has a climate plan. And part of that can be about how they travel to work and stuff as well. So we encourage them in different ways. And there's more work to be done there, certainly. There's earlier comments about the sort of embedding behaviour. And I think that ties in about our buses. And we run the free bus programme over the school holidays so that children and their families get used to going and jumping on a bus, because it's the nicest and easiest way to travel, and working very closely with the bus companies to improve the quality and affordability of their services is part of that. And if it's free, then it's going to be used, and that starts at an early age. I think mentioning school streets as well, yeah, it's a very valid point that they are challenging, and every school street is designed for that school and that community around that school. They're not just blanketly spread out and hope for the best kind of thing. And we have, the feedback we've had is that schools, communities and parents are delighted by the results of our School Streets programme. We have to remember that although, Councillor Lawrence mentioned about that impact upon the community and how it might make it difficult for an hour in the morning and an hour in the afternoon when the area is partially closed to through traffic, not all through traffic, and there is work to improve that. But prior to those school streets coming in, it was a nightmare of parents parked on pavements, jamming streets, in and out. There were accidents, people bumping each other's wing mirrors and stuff like that. It still goes on. I mean, if you've been down 3rd Avenue when Robert Napier's tipping out of an evening, it's really bad along there. And there's all sorts of other schools which still have these problems. And we forget sometimes, once it's been done, and there's actually no traffic around a school for that period of time, how nice it is, and you forget how awful it was when the parents were driving in. And even just over near my in-laws' house, there's a school there, and parents are starting to park up at 2 o'clock in the afternoon in order to get a space near the school to pick their children up. Well, that's got to stop. We can't live with that forevermore. It's been like that for however many decades, and it's got to change. So the do-nothing option and hope for the best really isn't satisfactory. We need to do something about the school parking issue and the school transport issue. And it's dangerous, apart from anything else. I think there's mention been made of planning and design codes and the neighbourhood plans. That's the one in Luton, is a neighbourhood plan, and those are really having an impact on how we can make improvements. So a simple one, it wasn't cheap, and we had to wait for the money to become available and do some fundraising as well. Outside the school in my ward in Luton, we managed to put a really good quality new school crossing opposite the school, at the gate of the school. That's made a difference. More children are now walking into Luton Primary than they used to, because it's safer to cross the road outside the school. It's simple little things like that make a difference. So we can do it, but it takes time. And I think also, just to remind colleagues, that the local transport plan is currently now being revised. It's got to be published again at the end of next year, and the consultation of that has started. So there is that happening. So just sort of to close off, the importance of what we're doing probably is wrapped up really neatly in the appendices to the report that we've seen today. And you can see how brilliant and how cross-cutting and how wide-ranging is the work that the team have been doing over the last couple of years on all this work. And I think it does go to the heart of what we mean by sustainable development. Doing this work on active travel goes to the heart of our environment and makes improvements to air quality and everything around the environment that we treasure so much. It goes to the heart of our communities, bringing about greater health and well-being in the communities as well. And it goes to the heart of the economy. If you've got less congestion, then the economy is better off. Things are moving more quickly and more smoothly, and all sorts of benefits that come out of that. And I think the one thing that really sort of wraps it up as well, and this you see quite a lot of, it improves happiness in the community. If you haven't got that congestion of traffic, people feel that they live in a much better place, and they're a lot happier for it. So the work that they're doing is fantastic, and I really thank the board today for hearing them out and listening to what's been done. Thanks very much, Chair. Thank
you, Simon. Great testimony to you, James, Darren and Chris. Thank you very much for all of the work you do, and just sharing with you, I think Simon is right. Once you get people walking, and this has happened in my own ward with a walking bus to Crest Infant School, the 2 playgroups who are nearby have now started to walk the children to have some time in the forest school that there is at Crest. So we've got the under fours doing their own little walking bus and coming along to enjoy the forest school when it's not being used by the children in Crest Infant School. And I was talking to the leader of one of the nurseries that's taken up the offer of doing that, and she felt that the children's confidence had improved even at that early age, with how they feel about being out for a walk. And obviously the nursery are teaching the little ones road safety, so that all of this starts early. And I think, you know, when you take an action, it does begat a reaction and a response. So thank you, everybody. I'll go to the Vice Chair for the recommendations, and as we've gone along, Jonathan, Stephanie's been taking a note of the other things that have come from the meeting. So if you can take us to the recommendations, please.
So the first recommendation is that the board is asked to note the progress made in promoting active travel across Medway. Second recommendation, the board is asked to support continued cross-sector collaboration to improve adult walking rates. Third, the board is asked to encourage partners to promote and participate in active travel initiatives. And the final one, the board is asked to consider how its partners can assist to identify opportunities to align resources and strategies to improve performance on the walking indicator.
Thank you. Is that agreed, everybody? And just to reiterate Simon's plug that he made there for the appendices, because there's lots and lots and lots of information there that can be easily shared with other people. So thank you, everybody. And we'll move on now to the Medway Safeguarding Children Partnership. And Anna's here to introduce that item for us. Thank you, Anna.
Thank you, Chair. So, as you'll see from the slide, so the Medway Safeguarding Children Partnership works under the statutory guidance of Working Together to Safeguard Children 2023. The guidance acts as a framework for all safeguarding children partnerships in England. As you can see, it was updated in 2023, and it strengthened the shared responsibilities for the three statutory safeguarding partners of Kent Police, Medway Council and NHS Kent and Medway, as well as the inclusion of education partners in multi-agency safeguarding arrangements. So in terms of some of the headlines then for our 24-25 annual report. Thank you. So in terms of governance, so the executive group initiated the process for reviewing the Safeguarding Children Partnership Strategic Plan and also secured post-16 education representation at the executive group. So there's now representation across primary, secondary and post-16 and alternative provision partners. In relation to scrutiny and assurance, the annual report includes contributions from the independent scrutineer for the secure estate and also for the multi-agency safeguarding arrangements as set out in Working Together. So for the secure estate, it includes an assessment of the preparation for the opening of Oasis Restore Secure School and the relationship with the Medway Safeguarding Children Partnership Secure Estate Safeguarding Assurance Group. In relation to Voice of the Child, the annual report now includes information from the statutory safeguarding partners on how they seek the views of children and families and then utilise this in their service development. So we have examples from Kent Police in terms of their community forums, including young people, to comment on public protection strategy. For Medway Council, the work of the Family Hubs and Start for Life programme and their dedicated parent carer panel set up by Medway Parent Carer Forum, and NHS Kent and Medway engagement and consultation with children and their families for the procurement of the Medway Therapeutic Alliance. In relation to progress against the priorities, so some of the headlines were in terms of within effective partnership, the MSCP has reviewed and published the threshold of need for action and guidance for all of those working with children and families in Medway. And we work closely with other strategic boards, so you'll see information in there in respect of domestic abuse and the Medway Local Partnership Board. In relation to learning and improvement, the report sets out the headline findings for our Section 11 safeguarding audits and the progress of the Section 175, 157 safeguarding audits for schools. These are self-assessments for schools and other agencies which the MSCP uses to provide assurance on how partners are working to safeguard children, and they include standards relating to leadership, policies, procedures, training and recording. So our headlines for this year. So in terms of governance, there's the executive group have undertaken a review of the partnership structure, considering the strategic plan, themes and priorities. In relation to our scrutiny and assurance, there have been some changes in the independent scrutiny arrangements in relation to the secure estate, and the independent scrutineer is also undertaking work in relation to child sexual abuse, in relation to the response from national reviews and Medway multi-agency audits. For the voice of the child, there's a priority for the executive group to work towards a child-centred approach to be included in the strategic plan, cutting across the work of the partnership. And for the priorities, we've identified the need to review the contextual safeguarding strategy and the neglect strategy for approval by the executive group. And also for that to link with a review of the multi-agency performance data that's developed by the partnership. And finally, but no means least, in terms of learning and improvement, currently the Safeguarding Partnership has 4 local child safeguarding practice reviews that are running concurrently. Thank you.
Thank you, Anna. And sorry, I didn't turn my mic off when you were speaking, but I think hopefully everyone heard what Anna was saying. The report reminds us that we've got 64,000 under-17s to look after in Medway, and it's important that we're mindful about their safety. I'm really pleased to say that next Tuesday we'll be raising the flag for the White Ribbon campaign, which tackles domestic abuse, because sadly we have seen a rise in domestic abuse in Medway. And of course, the level of trauma that domestic abuse causes for children then gives them the possibility of becoming an abuser themselves, mental health problems, and other problems associated with schooling. So for us, that particular joint priority is very important, and we're having a special focus on it, in addition to working, as Anna said, as a partnership with the police, and still focusing particularly on the safety of women and girls. So there's a lot going on, and it's important, I think, for us in the adult population to shout loudly about the fact that we want children and young people to be kept safe, and we recognise some of the dangers and potential dangers that they face. So with that, I'll go to Mark first, then Andrew, please.
Thank you very much, Chair, and thank you for the report. I particularly wanted to focus on pages 12 or 78 in the papers and page 13 of the annual report, page 79 in the papers. So there's clearly a lot of good work going on around domestic abuse, violence against women and girls, and in terms of learning from those incidents that occur. What I was going to ask was a little bit more about the stage before that, about the prevention aspects. At the last meeting, we had a very interesting discussion on identifying very young children who might be in danger in later life of offending. It's always very difficult for counsellors to talk about these things because we sound as though we're stereotyping particular families, which is not my intention at all. But there must be somewhere a system which perhaps isn't fully reflected in the pages of this report of identifying families where support needs to be given to parents and children and carers in terms of things like parenting skills, to throw one thing into the mix, one important issue into the mix. So I wondered if, within the time available, I could find out a little bit more about these prevention aspects. We learnt last time of the work which is being done with the youth offending team and the youth service and the police. And it's obviously about wider community support, using the hubs and that sort of thing. I suppose it starts with the midwife. And then, we're talking on this board about the link up between health and social services and education. And then we go on, presumably, to all join up and, hopefully people are getting the advice and support that they need, which then prevents later problems. Thank you, Chair.
Thank you. Yeah, in terms of that early help preventative work, so the Safeguarding Partnership has a training and development programme for those that work with children and families in Medway. So that's volunteers, people in paid staff, frontline practitioners, managers. It's well accessed by a range of professionals and includes kind of introduction to safeguarding topics like domestic abuse, like child sexual exploitation, as well as then what our kind of more detailed or in-depth training in relation to that in-person training like domestic abuse. So in terms of that professional development, for those people that are working directly with families, absolutely there's a focus on identifying signs and indicators as early as possible, as well as the focus on taking action when there's evidence of a child that's at risk of harm. It says in the annual plan about our threshold document. It's not a very user-friendly title. It's a professional document, but it absolutely sets out the expectation of the Safeguarding Children Partnership of that early identification of need that's expected of everyone working with children and families. In the report, in the effective early help section, there are some updates there in terms of some of the partners' work. So as you'll see, the Family Hub piece, things like the Medway Family app, that the partnership supports and promotes, as you quite rightly say, so that the wider workforce, the wider community is making that contact with children and families as early on as possible. We have midwifery services are part of our kind of structures, if you like, so community midwifery as well as the specialist team, so they're part of our learning from our reviews and part of our kind of proactive work where we do our multi-agency audits. So yeah, there are certainly some of the ways that the Safeguarding Partnership absolutely wants to promote that message of building those relationships with children and families early on in their life and early on when a problem is arising.
Thank you, Chair. I recall this report from last year, actually, or last time it came here, and I found it an impossible read then, and it remains a fairly challenging read now. I don't know who the audience for this report is, but thank God for Gemini. That's all I can say. I've got just a number of questions. I was struck by the number of children subject to early help in Medway as a comparator to the rest of the country, and I'm just wondering what partners have got. What is the plan to challenge that? The number of children who are subject to early help. What is going on in Medway that's not going on in other places? I don't think the report really addresses that particular issue. I was also very struck by the 97% increase in the use of professional challenge. Now, we definitely discussed that last time round. And I think there was certainly a recall about this. We seem to be seeing more of this, and was it a cult? What was going on? And clearly we haven't grappled with that in the last 12 months. So I'm just wondering, what are the tangible actions that the that statutory partners are going to take to address the root causes of that. I mean, particularly the lack of action and not following procedure. I mean, what is going on? I mean, from last year, you guys have got assurance documentation coming out of your ears, but it's clearly not being used. Is it just, you know, files on a shelf? And, you know, so for me, there seems to be a massive lack of training that's, you know, is it going to lead to something substantial happening to a child? I definitely remember making this point last year as well, which is there's an awful lot of doing in this report, but what is the impact of the doing? How are we measuring the impact of all the assurance work and everything else? So there's, you know, where is the quantitative demonstration between the strategic activities and the actual improvements in safety and well-being? That's just not in this report. Chair, there was one other point, if you don't mind. I'm very aware of the fact that there is anecdotally an increase in malicious complaints against practitioners, whether in schools, across the board. In actual fact, my son was subject to a particularly pernicious complaint. And I'm just wondering whether this is recorded anywhere. The impact of a malicious complaint on an individual is very serious. It can be serious for their career. If it's not upheld, you know, and there's lots of things. And I'm just wondering if the board could consider finding ways of measuring those malicious complaints against individuals. I think it's really important that we get on top of that because, as I say, the actual outcomes can be really very detrimental to the person subject to that malicious complaint. Thank you, Chair.
Okay, thank you. Before you come back, Anna, you know, I understand the fact that you're saying we heard some of these things last year. We will continue to hear them. The idea of safeguarding, as I'm sure you know, is to have an early investigation into a report and an intervention to prevent things from getting worse. So I don't think that we will see a diminution. And when we're thinking about impact, the impact that I'm looking for is preventing something worse happening, which of course is difficult to quantify, but that's the idea of the early interventions. It is correct that we've got more referrals, certainly than our comparator authorities, through early help, but I take that as a positive because it means that further down the track, we're hopefully managing to halt some of the problems. But I'll go to you, Anna, to respond.
Thank you. I would say that the structure of the annual report is set out in working together in terms of what the annual report must contain. Absolutely, take your point in terms of the readability of that. So, yeah, but the requirements are set out in working together. In terms of, I'll just pick up the malicious complaints. So working together to safeguard children is overseen by the Department of Education. They're currently proposing a revision of working together in 2026, and currently, as part of their engagement events, they are considering some additional guidance around malicious complaints. So just to pick that up. In terms of the early help, the numbers of early help, so the Early Help Partnership Board considers data around those things, around those numbers. At one of the more recent meetings, there was some discussion around comparators, and there's not a kind of agreed way of if you like, counting early help interventions like there is for child in need plans, child protection plans, because different areas will have different arrangements for that provision. So, yeah, it's noted that those kind of comparisons that may happen in children's services is more challenging. Children's services colleagues would always rather families be helped in an early help context as well as our other partners. So similarly, really, in terms of having evidence that families in Medway are receiving early intervention, actually was seen as a positive as opposed to, so because some areas are not counting what we might call community help, early intervention. You mentioned about the professional challenge. Could you just say a little bit more about that? Is that okay?
Yeah, so if you look on page 26 of the report, which is page 92 of the overall thing, it talks about multi-agency data sets, professional challenge and escalation, 97% increase in the use of escalation procedures at stage 1, 2, 3. There were no stage 4 escalations. And then I think it goes on to talk about some of the reasons, which are lack of action and not following procedures.
So, thank you. So we, the partnership, have actually encouraged partners to use the escalation policy. There's been learning from national reviews and some indicators from our local reviews where there had been professional disagreements and those partners had not formally taken that forward of each other, and as a result children have been harmed or sadly died. So we have made a deliberate decision to encourage the use of the professional escalation and challenge policy so that it mirrors that openness and transparency across the partnership in terms of action or inaction where a child is at risk of harm. So that's some of how we've seen that increase.
Sorry, it's on the same point. Might actually be quite small.
Back to you,
Thank
Andrew.
you. I think that is a really good point. But I think also, what's the follow-up to those actions? You know, disciplinary training, support. Because I think I know you're trying to create a reasonably positive picture, but there are some issues. And Chair, I have to say, knowing you as well, I'm getting to know you better, but I thought that was desperately depressing, your comments about this is going to continue, that children... Now, maybe that is the reality, and I'm hoping we're sitting here actually trying to improve and, make suggestions, but are we just accepting the fact that children are going to be harmed, that there's nothing more we can do? Thank you.
It isn't about accepting that harm is an inevitable consequence. It's about making sure that if people have any doubt that something is going wrong, they feel confident to be able to report it and that something will happen. And I think the more that we explain to people that there's a possibility of doing that, then we will continue to have these reports. And the sooner we act on them with early help, the sooner they are less likely to lead to something worse happening. So, no, I don't expect that things will diminish in terms of the number of reports, but I hope that in terms of preventing harm, yes, we should see that actually happen. And I think, it's really important to address what you said about vexatious reports. They do happen. Children's social services have to cope with that. And I've had experience of that directly in my own ward and spoken to practitioners very often. If there has been a family breakdown, the two sides of the family will make vexatious claims against each other because there are wider grudges. But I can assure you, I'm afraid, that every single one of them is investigated. And I have myself thought that we ought to be able, we haven't got statutory powers at the moment, but I think that they should exist where people persistently waste social workers' time with a vexatious or a malicious complaint, that there should be some sort of penalty, because I'm afraid there has been a rise in doing that. But we can't take the chance. So for all and ever we're doing children's safeguarding, I'm afraid we have to accept that some of those things are, not correct and never were, but we have to treat them in exactly the same way as a more serious harm prevention would happen. If there are no other speakers, there are. So Simon and Eddie, please, and then I'll come back to Anna.
Yeah, thanks, Teresa. Sorry, I didn't get my hand up quickly enough. A couple of questions, actually kind of following on from the conversation that was raised there by Councillor Lawrence in some respects. I mean, I can understand how agile you have to be all the time, because this is a changing situation year on year. Things move on and are done differently, and there are issues that come up that you haven't anticipated. It's the nature of the problem that we're trying to address here in many respects. And in that respect, it's about the real question, or two areas really. One is around the nature of the partnerships that you have. I mean, you talk about the 3 statutory agencies, and there's an issue around the police not having the right representation. And hopefully a bit more on that, if you don't mind, and how has that been resolved, and you're comfortable. But are those partners and agencies working as best they can now together? Or is there improvements that can be brought in? I know within that you've got this learning and improvement section, you've got stuff around multi-agency audits and the effective partnership working. That's in the report. But are you comfortable with where things are, or is that another constantly changing environment that you have to manage all the time? And then the other issue really comes to the heart under the partnership contributions, and a shortfall of a £50,000 shortfall in the budget and having to make that up. And then I look at the contributions, and our Medway councils, but the other contributions are pretty small, actually, to be honest. And I'm just wondering, because particularly if you then have an issue, the cost to any of those agencies will be well in excess of the contribution they're making. And actually that £50,000 isn't that difficult to make up between that range of contributions. Is it time to ask those agencies to say, look, you need to give a bit more here, because this is so important, and going back to what I was saying about how agile you have to be, I'm a little bit concerned about those numbers. Thank you, Chair.
Yeah, picking up on the concern about malicious accusations, as you rightly said, every single one needs to be investigated. Now, in the world I work in mental health, making accusations from residents we support happens all too often. And you may hear an accusation, and I must admit, and you hate it, oh, how ridiculous. But for a variety of reasons, including they need to know they've been listened to, it just might be true. However, there is this nonsense that a lot of people believe in, which is there can be no smoke without fire, however that phrase goes. That's not true. Some people just blatantly lie and make things up. What my concern is then the impact on the members of staff. So it's not just resident to resident, but myself, nearly all my colleagues at some point are being accused of a variety of different things, and our well-being, because you know, if you've got a conscience, that sticks with you, and you do worry about your reputation. So I do hope there is a culture within Medway that there's that support for staff when this happens. When it comes to the report itself, I actually really like the summary right at the end, because when you think back to some of the worst cases of abuse, and when, you know, say a child has died or whatever, it's quite often it's been a case of those involved, particularly social services within that borough, haven't taken action, and you do worry about what were the reasons. So the idea of championing confidence, making sure that there is shared learning with the team. So hopefully we have in Medway a sense of, to some extent, being relaxed, be able to share concerns, even if it's unfounded, because sometimes actually intuition is really powerful. You shouldn't make assumptions, but you need to have that culture where people can talk with each other, share their professional approach. And one of the points where it says professional curiosity sounds a bit lame, but actually that's really important, because sometimes you can know without necessarily being able to pin it down that something is not right. You would have heard me say before that I'm not 100% confident with the safeguarding in Medway, because the 2 experiences I've had, maybe that's changed since then, but I'm pleased to see that there is at least, so there's a statement of culture here that I'm glad to see out in the report, right at the end, about confidence and looking for signs and symptoms of abuse and all those steps, so thank you for that.
Thank you. So, Anna, some final reflections from you before I go to the Vice Chair, please.
Thank you. So to pick up the piece in terms of the nature of the partnership, so there have been some changes in terms of the delegated safeguarding partners and the lead safeguarding partners. They have joined those the partnership, the structures, making contributions early. We have good attendance at meetings. We have good engagement at meetings. So, and the Medway Safeguarding Children Partnership is meeting the requirements of working together in terms of those 3 statutory partners, the systems, the processes, as well as evidence of collaboration, what that kind of the impact of that, what that really means for children. So absolutely, it's yeah, we're one of the areas where we're fully embedded in those updated guidelines. Absolutely, the change in nature, and that's what our independent scrutineer has picked up in terms of a structure that is flexible and agile. So one of the changes is to move to task and finish type arrangements as opposed to established kind of long-standing subgroups, but actually to identify those key areas of practice set up, and we've already initiated 2 of those, or the partnership has. So contributions, absolutely, in working together, it says that partnerships should strive to equal contributions. The executive group have made a commitment to that, and that's been work that's been going on, and also considering education partners, what that might look like in the future as well, because there are some partnerships that, given that education should be considered as a statutory partner, their contribution to that. And last but by no means least, just to pick up the piece about the learning, you'll see in the report there's a process for rapid reviews when a child dies sadly or is seriously harmed. The outcomes of those rapid reviews, those reports are overseen by the scrutineer, and we've had positive feedback in terms of the process that's followed, because that's a statutory process, but also in terms of the outcome of honesty and transparency, both in terms of what needs to be improved on, but where there might be strengths as well in individual partners that we can take forward. So absolutely, that culture, that leadership is, you know, some of that oversight, some of that quality assurance, there's evidence of that in our statutory processes. Is that?
Yeah, thanks very much. I'm just wondering on that contributions issue, is there anything that we can do as a board to so encourage those partners to say, look, you need to look at how you're doing this? Because I think that's quite a key point. It's not a huge shortfall that you've got on anything. I know how difficult budgets are, especially for us as a council, but equally, it's not a massive amount there, and this is such a massively important issue. So I was just wondering if there's any more we could do on that issue.
If you come in, Leanne, please, and then back to Anna if she's got something to add.
Thank you, Simon. The budget is looked at all the time. The chief accountable officers who meet twice yearly, so the chief exec of Medway Council, chief constable, and the chief exec of the ICB, all of that finances information is put before them. The partnership as itself will make those decisions, and it's important that we're flexible enough to make those decisions. There is a process, and at the moment there is that shortfall, but I'm not sure that the Health and Wellbeing Board at this stage needs to get involved, but your comments are noted. This discussion is really interesting because this is about safeguarding children. It's about children's health and well-being. And, you know, in my job, every day I wish I was wrong. And it's a funny old job. I wish I was wrong that X family has an issue with child safeguarding. I wish I was wrong a lot of the time, but unfortunately we are right. And the strength of this safeguarding partnership is that all partners have signed up to a safeguarding threshold and everyone plays their part. So last week, for example, in Medway, we had 244 contacts, meaning somebody picked up a phone or went onto the portal to report a safeguarding issue about a child in Medway. From that 244, social workers, police, health, education will work on those contacts. And from those 244, 75 turned into bona fide referrals. 75, that's 3 caseloads. That's 3 caseloads for social workers. That was just last week. Now, that is a lot to carry through all the time. It is just relentless for those social workers. So of course mistakes will be made. Of course they will, you know. But this safeguarding partnership has got enough safeguards in place for us all to hold that risk. So I'm really, really pleased with this report, and I want to pay tribute to Anna because since she's taken up role, she's really strengthened this partnership. We have our independent scrutineer. We absolutely are trying to get all these building blocks in a row. So the safeguarding of Medway's children can always be improved on. I don't deny that. It absolutely can, and you know, we're due Ofsted next week, and Ofsted will leave us with a letter, and they will tell us what we're doing right and our areas for improvement. And that is right. That overall scrutiny, the safeguarding of Medway's children is all our business. But I would commend this annual report to the Health and Wellbeing Board, because I think when you get underneath all of this, the health and well-being of Medway's children regards safeguarding is in a good position. Thank you, Chair.
Thank you, Leanne, and I think it's absolutely right to recognise the work that goes on. The other thing, just for my assurance really, Anna, is that the information that is garnered about children, should it be something that continues to need to be worked on, a guarantee that it transitions with them as they become adults is important, and I just wonder if you feel that that definitely does happen.
So certainly from discussions in partnership groups, there's conversations around the systems that education partners have from primary to secondary. And the executive group have identified an area of one of those task and finish groups around transitional safeguarding from children to adults, both looking to work with the Kent Medway Adult Safeguarding Board as an area of focus in terms of that additional assurance around those arrangements and the particular risks, and that's learning from national reviews as well as those adults reviews. So certainly in terms of the kind of day-to-day processes, but yeah, transitional safeguarding has been an area that's been identified for further work between the two partnerships.
That's good. So hopefully we'll see that coming up in next year's report. And before I go to the Vice Chair, I think the other thing worth mentioning here for the board is the commissioning of the Medway Therapeutic Alliance, which I regard as a real piece of innovation. Grateful for the support that we've had from the ICB for that. The Therapeutic Alliance will be, we've got a delivery partner now. It will start in April. And what will happen is that children and young people who get a mental health referral will be able to access interventions from a range of partners before a psychological or a medicalised intervention happens. Of course, those who need that urgently will still get that and will be more likely to get it more quickly because the Therapeutic Alliance will be working on everybody else. But in terms of safeguarding, in terms of children's and young people's mental well-being, this is a real step forward that the agents of help will be brought in at a very early stage and be working with children and young people on a range of different therapies to move away from a medicalised future always being the outcome of a mental health concern. So we're looking forward to that coming forward, taking pressure, I hope, off CAMS, and most importantly, providing opportunities to make an intervention before a child or a young person becomes somebody who has got frail mental health and as they grow up are not in a position to realise their potential. So, you know, and it's very clearly a part of safeguarding, being able to pick that up. And so looking forward to seeing how all of the partners contributing to that with the delivery partner, North Kent Mind, who have been commissioned, go. And I would like to see something similar be constructed for adults. I think that's, we won't stop with children's, and we'll think, very, very carefully about how we can make sure that activity transitions. But it really is something very welcome. I commend our public health team for putting it together and working with the ICB and others to make that happen. So, over to you, Vice Chair, for the recommendations, please.
Thank you, Chair. The board is asked to consider and comment on the annual report, including where they can support and assist the MSCP priorities for 2025-26.
Okay. Thank you very much. Is that agreed? Okay. Thank you. So our next item is the suicide prevention strategy introduced by David Whiting. When we've finished that item, and with particular reference to what I said at the beginning, we will have a short break. Okay, thank you.
Right,
Yes,
great, thank you very much. Actually, I'd like to just hand straight over to Sophie to talk about this.
Okay, thank you.
Thank you very much. Thank you, Chair. Thank you, David. Lovely to be with you all today. My name's Sophie Kemsley. I work for the Kent and Medway Suicide Prevention Programme as a Senior Project Officer. And I'm here to give a little bit of a talk around our new strategy for 2026 to 2030 that you will have seen in the report papers. So this strategy has been developed off the back of the existing work that the programme has been doing. We're coming to the end of our strategy for 2021 to 2025, and during this time we have seen many things that we are pleased about, but equally many things that we would still like to change. Our strategy has been developed in conjunction with our networks, which are a massive part of what we do. So our programme is a team of 4 members of staff, so we're very small. We're based within Kent County Council's Public Health Division. We are funded by the ICB, and we work very closely with our partners in Medway, so Scott and Sarah, and our Suicide Prevention Oversight Board. Our networks are made up of around 250 attendees from all over the sector and system, and we have all come together over the course of the past few months to put together our new strategy for 2026 to 2030. The strategy is a single strategy for adults and children and young people. There are 2 action plans that are separate for both, though. And they are both very similar in terms of priorities. They're exactly the same 8 priorities, but they have been adapted ever so slightly to reflect the different approaches that may be needed for adults and children. The strategy was drafted in the spring of 2025 and was out for public consultation from the 23rd of July to the 6th of October. It achieved 149 responses to the questionnaire, and a consultation report has recently been completed with the responses all read individually and the answers to every single questions analysed and put together. At the moment, we're only able to share the executive summary, which has been included in the papers, and what you'll see from this is that there was broad support, overwhelming support really, for the vision, mission, aims and priorities set out within our strategy. Our overall vision is to bring down the number of people dying by suicide in Kent and Medway as much as possible. And our mission is to achieve this by instilling hope across the community. And we will do this with our 8 priorities that we have set out. I will quickly read through them here. So the first one is around making suicide everybody's business. So recognising that it's not just the role of a single team working in a single organisation, but is down to all of us across the system to know how to play our part. The second is around addressing common risk factors that may contribute towards suicide and thinking about what we can do around those. Thinking about high priority groups and thinking about how they may need tailored and targeted support, but not, of course, forgetting that suicide is something that sadly anybody can be at risk of. So our strategy is designed to work for everybody, but we do have to consider data and evidence that suggests some may be at higher risk where this data and evidence is available. We'd like to provide effective crisis support across sectors for those who most require it. We are not a frontline service, but in our role as system leaders within this field, we hope to be and work to be and have been in the past sort of hugely influential in this regard with how we work with our partners in addressing this. We aim to continue to use data and evidence to support the work that we do. So our real-time suicide surveillance system, which we use with Kent Police to inform the work that we do and to tell us in the here and now what we are seeing in Kent and Medway and what we need to do in response to that. We'd like to reduce access to the means and methods of suicide, so working with partners, for example, our colleagues on the railways, those working in sort of country parks to think about what we might need to do to reduce the likelihood of suicide in these areas. Promoting online safety, a very tricky one to do, very hard to police, but essentially something that we can still influence by working with our colleagues in communications to promote positive stories in the media, so things like the Baton of Hope, which you'll have been aware of recently, and doing what we can to kind of share more positive stories and respond accordingly if we see things reported in a way that we feel is insensitive to the lives that have been lost. And finally, around providing effective bereavement support to those affected by suicide, and be that as friends or family or as witnesses or anyone affected as anybody could be. So those were our priorities. We do not anticipate changing our priorities on the back of the consultation. In fact, there is not a huge amount that we will be looking to change in the final strategy. But that being said, we have received a number of comments that we are sort of paying consideration to, and we will be making a few amendments. However, these will not substantially change the content of the strategy. So what you will have seen already in the papers is a very good sort of reflection of what it will look like. But I'm happy to sort of hear any sort of initial thoughts or any questions people may have around how they can sort of use this strategy in their own workplaces. Thank you.
Thank you very much, Sophie. And I think it is worth, reminding the board that between 2020 and 2024, the report tells us 721 people lost to suicide in Kent and Medway, 75% of whom were men. It was International Men's Health Day yesterday, and I think we do have to be very mindful of the way that we put support in place for men who might be at risk of suicide to speak up and to get the support accordingly. I think the priorities are right, and I think the priority groups are right, and I suppose taking a positive from the table on page 6 of the report, page 113 of the agenda, is that the focus that we have collectively got on gambling awareness, on domestic abuse, are the right things, that we can muster collective resources to prevent people getting into situations that make them feel suicidal. So that is welcome. And what we were saying earlier about young people, 14% of those people who died were under 25. So we can't ignore the red flags that we see through safeguarding as might be associated to suicide. And can I say, I do think and continue to lobby for much stronger work on social media. It's absolutely disgraceful and sickening that some of these sites encourage people to take their own lives. And we've seen evidence where particularly young people and vulnerable young people, particularly people who are neurodiverse, have been influenced by them. And I do think nationally and internationally there needs to be very strong action about those. But with that, thank you for the report, Sophie, and I'll open it up for comments.
That's great. Thanks very much. And thank you very much for the report. I mean, obviously, this is a very difficult issue to cover, so the language is quite hard as well. And it's good to know that the work that you're doing is probably never ending in many respects. And I think there's not many of us who've not been touched in some way by people who are in this sort of state where they feel this need to take their own life. One thing that came out, I wanted just to mention, and I hadn't picked it up until I read the report about country parks and the green space and stuff like that. So I will be going back to the teams that I'm responsible for within the council just to have a word with them. But one thing that did come up quite recently, we're just about to publish our river strategy for Medway, and I hadn't realised that the number of attempted suicides and suicides in the River Medway has gone up significantly since COVID. And that's a report from the rescue services, fire and rescue services. So that's an issue that I was aware of, and I just thought I'd mention it at this meeting. So when you, on page 9 of your report, where you talk about access to means of suicide, then that's, I mean, that's, I'm not sure what the answer to that is, apart from more information by the river in order to let people know there's help available out there, you know, that sort of thing. But certainly that's something I picked up on. Thank you, Chair.
Okay, thank you. I've got Andrew next, and then Eddie, please.
Thank you, Chair. I'm aware of, very recently, of 3 suicides, 2 involving trains and 1 actually at Hempstead Valley very recently, which sort of, it does bring it home. I thought that it was an interesting read, this report. I just note that this is for Kent and Medway, but I think Medway has some very specific challenges. If you look at the suicide rate for Medway as opposed to Kent, it's a lot higher. And the stat that I was quite shocked by is that the suicide rate in Medway has increased by 13%. The latest statistics suggest. And I was just, you know, one of the things I was going to ask you was around what are the plans specifically for Medway, rather than, because we've seen this in health before, where you have a Kent and Medway strategy, but Medway seems to be the poorer cousin of that part of it, but we've got very, very specific needs. Based on, so it was really around governance and accountability and, you know, budgets and things like that. In terms of stating the obvious, because there has been an increase in the suicide rate, the previous strategy may have had some successes, but maybe not as many as we hoped. And I'm just wondering what's different about the new strategy. I think you said there's not going to be anything different, but that would suggest we do need to do something different if the suicide rate is increasing. I was wondering if we're going to set ourselves any target for suicide reduction as a part of that strategy. And I think my final question, Chair, is just around, clearly this is a multi-agency. I think as Simon quite rightly said, it's not one team are going to solve this problem. So what mandatory interagency training is there in place? You know, and how are we following that through? How do we assure ourselves that those agencies at the front line of suicide are you know, they're getting the right training? There was just one more comment, really. I'm just reading here that actually the self-harm admission rate for 10 to 24 years old in Medway is far worse than the national average. And have we got an early help strategy in place for that particular group? Because I wonder if you look at people who do commit suicide, if they start off with self-harming and it just progresses because they're unable to, you know, we're unable to support those people. Thank you, Chair.
Yes, Sophie, please, you want to come back? Thank you.
Thanks very much. I think it's on now. Thank you very much for your questions. I was making a little note of the questions being asked, so hopefully I will be including all of those. So first of all, Councillor Curry, just in terms of your comments around the risk of waterways, absolutely, that's a really sort of key point. We do have a sort of close working relationship with our colleagues who sort of work in different landscapes, so things like the lifeboat service and Coast Guard, and we've received data to see if there are any sort of particular areas where we are seeing particular incidents of threats of self-harm, for example, and where sort of an incident may be Medway specific, we will work very closely with our colleagues in Medway, so Scott and Sarah, to share that information. And I know that they have a very effective mechanism in place in terms of making adjustments. And a couple of examples I can think of is around the Medway Bridge, where there was a lot of work done in terms of raising the parameters of that bridge to reduce the likelihood of people being able to sort of scale it. So what I'm saying by that is that this is something that's very much on our radar. We do have a very diverse landscape in Kent, and there are lots of very natural risk areas, and we are sort of quite confident in the kind of relations we have across our system in terms of how we can be most aware of the areas that are at particular risk, and we have the contacts in place to sort of initiate what we might be able to do around that. So moving on to sort of the questions around the rates. So one thing just to kind of acknowledge from this is that the data that we used for our data and evidence pack was off the back of the ONS statistics that were published in 2024. They are only published once a year and they come out in autumn. So that means that we didn't have the 2025 statistics when we were putting this together. The 2025 statistics for both Kent and Medway are showing a decrease in rate. Particularly, there has been a sort of substantial jump in Medway, I'm very pleased to say. So that's a really encouraging sign, but obviously within our programme we are very hesitant to rely too much around sort of rates and data because they are all recorded in different ways. So what I'm saying by that is that we would never be complacent and think, oh, that the rates are coming down, that's great. But we will try and take the positives of it where we can and think that, okay, so what we're doing does seem to be having an effect. One of the sort of good things about our strategy is that although we have some sort of key things that we are trying to achieve and key things that we will look within that, it can be very adaptable to around what sort of happens and what emerges. We can be very reactive when we need to be. So, for example, if we were to start seeing a particular increase among a particular demographic in a particular area, we could do some geo-targeted release the pressure campaigning to make sure that, okay, we're seeing this series of events in a particular area among a particular age group. Let's get messages on those phones. Let's make sure people are aware of the help that's available. So that's sort of on that point. In terms of target, the general target that we have, and it is, you know, I know it sounds very broad, but it is to just bring that rate down, particularly below the national average. But I'm sure, as you can all agree, that, you know, we just want to bring it as low as possible, as much as we can. So even if we were to bring the rate down below the national average, that's still not enough. You know, we want to bring it down as much as we possibly can, but we have to recognise that there are sort of challenges within that, and we have to respond to things. And what I also forgot to mention about the rates is that the rates coming down in Kent and Medway contrast to the rates around us, which have been going up in other areas and in England nationally. So again, that's an encouraging sign about the work that we're doing. But again, we mustn't take anything for granted, and we must not at all get complacent, and we never would do in our programme. In terms of mandatory training, so one of the things that we commission with the programme, and one of the things that we will continue to commission, is suicide prevention awareness training. Now, this isn't mandatory as such, but it is something that we try and encourage all of our partners to do, all of their staff to do, whether as professionals or as individuals as well. So anyone with a sort of general interest in this subject. And the aim of that training is to make this a subject that people feel confident in talking about. We know that it's tricky. We know it's a very sensitive area. But equipping people with the skills to be able to ask a question if they think that something is not quite right with somebody around them. Give somebody the skills they need to have that conversation and whereabouts to signpost people to for support. In terms of mandatory training, I know that sort of within the secondary mental health services, we've got things like Stay Safe from Suicide e-learning, which is being rolled out. Again, one of the things that we're really keen to do within our programme is ensure that that take-up is sort of done, so working closely with our colleagues in the ICB. In terms of self-harm data, so there have recently been a couple of sort of county-wide self-harm reports produced. that have given us a lot of insights. Absolutely, it is something that we want to bring down. We know that around 23 to 24% of people who are dying by suicide in Kent or Medway have had a known previous attempt. And we have to ask ourselves why, if that information is known, is it sort of happening again? So again, it's a crucial part of what we do, and that's why this is the suicide and self-harm prevention strategy. And I know that this is an area that we're going to sort of look and do sort of more work with going forward, especially now we have those reports. And I'm just going to hand over to Scott to talk about Medway plans specifically.
Thank you, Sophie. And I just want to provide yourself and the group assurance. I find myself as an officer, sometimes it's challenging to work across Kent and Medway projects, quite a big system, lots of partners. I can genuinely say, and David will probably vouch, I say this at our meetings, this is a genuine Kent and Medway plan. There are some things where it's really difficult. This is genuinely is. We have 3 weekly meetings, a really good representation from ICB, Kent and Medway mental health colleagues, always there consistently. It's very, very rare. There's not full quorum there. Myself and Sarah sit on that group. Always there as well, and it's a genuine opportunity to say how do we work across that, and not thinking so okay, it's all about Medway. I'm not there to champion everything. It's where are the challenges, where are the opportunities. So it's a really positive partnership approach we have on this agenda, which is amazing to see. Specifically, as you mentioned, your ward, a couple of incidents. So just again, we won't go into specifics for obvious reasons, but we've had a recent incident follow-up meeting. So a cluster of healthcare professionals will be together, follow-up meeting about it in 2 weeks' time. We had our fantastic engagement from National Rail, cannot fault South Eastern. They're really proactive on this agenda, super supportive. So if everything you can think of that could be done, they're thinking about it, they're doing that, they're bringing their learnings from there. They have I'm super impressed by the rail companies and how they want to take that forward for all the right reasons as well. Within some specific things around Medway, within the funding we have, there's Hope Fund funding. Again, we are there making sure there's a decent spread across the county and across the geography, so Medway does not go amiss. And within those targets, there's specific targets. So it's hard to measure some of the interactions. So having that overall target around bringing reduction down, but some of those specific interventions will have targets. Okay, we need to support that amount of people with that amount of money. And a really good example of a really good Medway champion. We had our Better Medway Champions award ceremony last week. We rightly gave an award to the fantastic security guards at a Pentagon Centre. It is so easy to underestimate how amazing that team are around intervening with people, because as well as the Rochester Bridge, we do have a number of other key areas of concern, and what the team there do are incredible. So we rightly kind of gave them one of the awards, for Better Medway Awards, for the selfless work they do. Really strong presence on Baton of Hope from our Medway partnership as well. So again, it just reinforces that this isn't Medway isn't just ignored in this area. Our rate actually came down in Medway from 12 to 10.3 since the most recent data. So again, I'm sure that's a result of some of the targeted work which the team are all doing as well. So hopefully that's provide some assurance.
I'm going to just ask David to come in before you do, Andrew, and I'm aware, Eddie, we've still got you. Yep.
Great, thank you very much. I've got problems with my hearing aids at the moment, so anyway, just very briefly on the self-harm in those aged 10 to 24. So we have had a project team doing a piece of work on that, and the work has just been completed. So I'll get the team to provide you a quick briefing of the findings from that. And they're now currently scoping whether it would be useful to create a digital offer for children and young people to support them with emotional regulation and to prevent self-harming. So the initial project is completed, and now there's some new work that they're scoping.
Did you want to come back, Andrew?
Yeah, just two very brief points, Chair. Scott, I didn't quite hear the number that suicides reduced by in Medway. Yeah, that's great, thank you. And just a general question to the council officers is, do we do suicide awareness training with appropriate professionals within, I'm thinking about social workers, schools, for example? Do we offer that type of training? Thank you.
Sorry. Yeah, Chair. I didn't hear the question.
Oh, okay. Andrew's asking, do we do suicide prevention training with schools and social workers?
We do with social workers, schools, not across the board, certainly not at primary school level. Some targeted work in secondaries on a needs but must basis, yeah.
And it is offered. So again, we do have that. We have that offer of training. We've got some really good training, and we get really good feedback from our training provider for that as well.
And we've got the
trying to get my thoughts together. First of all, can I say how pleased I am to see that even the very existence of this strategy, and I was just thinking about, again, a changing culture. Yesterday, in recognition of International Men's Day, there was an MP that stood up in Prime Minister's questions and openly spoke about his mental health. When I hear named days, I must admit quite often in life, I have this thing going in my head. My initial reaction is quite often a reactionary one. Oh, what's the point in name? What a load of... Because that was the way I was brought up. It just comes to me naturally. And then I think about it and my brain kicks into gear and I go, actually, that previous prejudice I had, actually there's a reason for this. And some people might go on about woke language and all that sort of nonsense, but actually having a named day like this gives a focus, which I think is really important. And I think the culture change, especially with men, because I think women on the whole are much better at expressing themselves. So I'm sure I'm pretty typical. I grew up in this boxing world. My dad was very heavily involved in boxing. I used to box, my grandfather did, and all the language all the time was based on this, like, I'm a hard man. It makes me laugh and I cringe now, but the language I was brought up with, in, you know, the tough guy, man's man, he never, ever expressed any soft emotions. The only emotions that a real man would demonstrate is violent and aggressive and all that type of thing. That was literally my growing up as a teenager. So I was just saying how much more healthy it's got to be that we can now openly talk about our mental health issues and actually express, yes, I'm a man and I have feelings. And obviously this really applies to women as well, obviously. So my question that I'm leading up to is, how many years has there been a strategy? Is there any way of identifying any changes? I would imagine it'd be very difficult to quantify or even identify changes, but I'm just curious whether there, first of all, how many years, and over these years, has there been any signs at all about any improvement around this subject, please? Thank you.
Thank you very much for your question. So in terms of how long there has been a sort of strategy in place, so we had the previous strategy from 2021. I believe that we had one in place before that as well. I've been working in the programme since 2022, and already within that sort of short period of time, I've seen just how much more targeted strategies have become. When we look at the national picture, there was a suicide prevention strategy in place from 2012. It was updated in 2023 to last until 2028. And as far as I'm aware, and I could be wrong, but as far as I'm aware, before that 2012 date, there wasn't a sort of strategy in place as such. So this is an area that has been growing and growing on the agenda. It has become a lot more refined, a lot more targeted. We are seeing a lot of things come into place from having taken that strategic approach. When we look at support for men specifically, it would probably be fair to say that around 5 years ago, perhaps, there was an absence of support groups aimed largely at men. In the past few years, we have seen quite a lot of those kind of sprout up all over Kent, in particular things like the talk clubs, for which the programme recently gave some funding for them to set up new groups around Kent. We've got things like Dad Space, we've got Men Talk in Swale, which I appreciate are sort of outside the Medway area, but still sort of near enough to show that this is becoming more and more in the public domain. Even again, when... Sorry? Yes, talking sheds, absolutely. There is a greater understanding now, even sort of the Royal Foundation that's been set up, you know, around a fortnight ago, the National Suicide Prevention Network. It's getting wider publicity. People are speaking more and more about their mental health. It's no longer a sort of taboo subject, and it's moving in the right direction. And I think the longer we have these strategies in place, the more we learn and we evolve and we sort of move on. And in terms of knowing whether or not it makes a difference, I think one of the trickiest things about working in suicide prevention is that you will always know about the lives that are lost, because that data is easily quantifiable. You won't always know about the number of lives that have been saved unless people choose to disclose it, unless they choose to volunteer that information. So it does make it very hard to measure the true kind of impact of our work, but it doesn't mean that we will kind of stop doing everything we can. And when we do have sort of feedback, as we do from people who have used one of our commissioned services or people who have spoken about another project or service available, and they've described that as the difference between whether or not they're here or not, then it shows that we are getting things right, and all we can do is continue to learn, evolve, and carry out the research we need to inform future suicide prevention activity. Thank you.
Thank you very much, Sophie and everybody. Important work that we will continue to support and get involved in. I'll be looking forward to the conference next week. So I'll go to you, Jonathan, please, for the recommendations. And then we'll take a very short break, perhaps about 5 or 6 minutes, just to let people stretch their legs, because we've got 2 important items. We allowed a bit of extra time for the board today, because we have got the annual public health report, very interesting and a new angle there on health, and something of huge interest to the public, primary care. So thank you, Jonathan.
Thank you, Chair. The board is asked to note the report and discuss actions that they and or their organisations can take forwards to support the suicide and self-harm agenda locally.
Thank you very much. Is that agreed? Okay, so we'll have a very short break, please, and see you in a minute. Eddie making a return, so I'll start this item. Welcome to Suk and Ash for a very popular, with constituents anyway, topic on GPs and neighbourhood health. And we've spoken for your information about possible training for the board that we'd like to put together. Stephanie's been doing some investigations. We've spoken about it to the LGA regarding neighbourhood health, actually. I realise the whole thing is sort of still in development, but we're very willing to do that with you if it's appropriate to do so. And before anyone else mentions it, I'm going to say that, you know, we're clear as well that local government reform and the configuration of whatever the new authorities will be may have an impact on the way that we manage neighbourhood health. But what I would say to everybody about that is we are doing things now that are inherently good for Medway, and your neighbourhood is your neighbourhood. That won't change when we're talking about local government boundaries. So I don't think we have to worry too much about that. The interesting and, I think, prescient thing for us to do as a board and as a partnership and as a system is to, you know, understand what we should expect, understand what we want to get out of it, and put into place implementations and innovations, hopefully, that will deliver both what is expected from the 10-year plan and what is good for us as a local system. So with that, I'll pass over to whoever wants to introduce, please.
Great, thank you. So just to introduce myself again, so I'm Suk Singh, I'm a Director of Primary and Community Care at the ICB, and I think Ash, you weren't in the room for introductions, so I think you should introduce yourself.
Thank you, Suk. Hi, everybody. I'm Ash, I'm a GP by background, jobbing GP. I'm the Deputy CMO for Kenton Medway.
So, as Councillor Murray mentioned, there's two aspects to this report. The first thing was just an update on GP services, particularly in Medway. And then I think this kind of translates into what are we doing about neighbourhood health and how do we get to a position where we are delivering much more joined up care to the population to better meet their needs. So if I start initially just by giving a bit of a summary in terms of where we are with workforce, because workforce I know is quite a big topic of conversation that we have had in the past, particularly when we've looked at the GP Access Task Group and seen some of the work that we can do to try and get GPs to come and work, live and stay in Medway. What we have seen is that from the workforce figures that we've got for 2024 to 2025, there has been an increase in GPs in Medway. So we've got 5 whole-time equivalent extra GPs that are working in Medway, and we're seeing that trend also to translate into an additional nurse provision, administrative staff, but the biggest increase has been in direct patient care staff. So this is the wider workforce that exists in general practice to support the population, and that could be pharmacists, paramedics, other allied health professionals that are there to support the population and their needs. In addition to obviously just expanding the workforce, the other thing we do offer is a range of support programs to general practice workforce as well. So we've got a new to practice program, so that's help support with the workforce to come and work in general practice, provide some of that peer mentoring and support to them to make them actually want to, again, take that career and stay within general practice. We've also been working on some targeted workforce planning, so that's predominantly looking at how we can support practices to think about the workforce that they need that better aligns to the population health. So it does take that targeted approach again, looking at, I guess, what's the population health in their area, and then how can we start to target and recruit into roles that may better meet the needs of the population. And the Training Hub have built kind of an infrastructure to support kind of bringing our partners together to support them around that. The other thing that we're trying to do, and this is a bit of an expansion in terms of what we do in general practice, is that there's a lot of support that's offered general practice, but we don't have the same infrastructure for pharmacy and optometry and dentistry. So now actually what we're trying to do is pick up the learning that we've done for general practice to see how we can then build that into supporting our pharmacy and optometry dentistry workforce as well. And this does then translate in some of the work that we'll start to develop through our neighbourhood health work as well, which we can discuss a bit later on. In terms of how we measure practices in terms of their safety. So the CQC do assessment of GP practices, as they do with any other providers, health providers that we've got within the system. And we've just put a picture in terms of where we are for Medway practice specifically in terms of the rating. The one thing you will notice is that there's quite a significant proportion of practices that are unrated. And that's predominantly where we've had mergers of practices. So we will have seen, and that's for very good reasons, so it helps the sustainability of providers, and it helps make sure, I guess, where we may have some challenges that are particularly challenged, they've kind of had another practice that have merged with them and helped them with some of the sustainability and resilience measures. The other thing that's important to note is that where we have practices that have been rated require improvements, they have action plans to address those measures. So there's been, again, a proactive piece of work we support them with to look at, I guess, where some of those access issues or challenges might be. So whether that's clinical outcomes, whether it's medicines management, whether it's around access more generally, there is some support that we offer around them. But again, the trend that we've seen since the report we presented last year is there's been an improvement in the rating of CQC practices for Medway practice overall. In terms of getting to the detail of some of the support that we do offer, I'll pass over to Ash here, but what we try to do is look at our general practice in terms of a number of range of different measures to provide a holistic view for each of the practices that we've got, so we can really target our support and interventions to them. But Ash, do you want to just speak a bit about GP Resilience Matrix?
Thank you. So what we have done in Kent and Medway is to be able to identify the practices where we can give a targeted support. So we need to know which are the practices we need to support, which are the practices which need more resilience. So what we do is we have got three big domains. One is access. What's the access being provided? For example, we look at what's the NHS 111 activity, what's the 999 activity, what's the GP full-time equivalent workforce that's in the workforce, what's the number of appointments they're offering, what's the number of appointments they're offering in 2 weeks' time. So those are the kind of things we will look in access. We also look at the workforce. What's the nurses' full-time equivalent? What's the GP's full-time equivalents? What are the physios and other staff full-time equivalent in that practice? And the third and the crucial part is we also look at outcomes in terms of what's the hypertension rates management, how are they doing with the COPD, how are they doing with asthma. We will also look at their CQC ratings. We look at multiple domains. So all in all, there are about 41 different touch points we look at. And that gives us a comprehensive score to understand how is that practice is working. And that helps us identify, for example, there are 4 groups. You can have high achieving practices, you can have practices which you think are achieving, then you can have practices which are approaching review, and then we'll have practices which are review identified. Within the review identified also, we'll use a score system to tell us which are the practices we need to then formally go and target, support them in their resilience, so to help them move from being review identified to the next level up. So I'm going to pass back to yourself now.
So then what do we do with that? So we've got that information, and then actually it's then how we target our support to them. And so we've had some support that we get delivered by external delivery partners, so they go in and work with the practice and help them in terms of some of the things that they want to address. But one of the most significant things that we launched this year was what we called a peer ambassador program. So these are people that work within general practice across Kent and Medway and have done improvements in their own practice, and they can translate and bring that into another practice. So they're sharing their learning. And we've said this before, we've seen some really good examples in Medway as well of practices that are doing really good, innovative things, but then how do you scale and spread that across to other parts of the primary care estate and infrastructure? So they go and work with practices and help them with some of the most particular things that they're looking at, and some of the things that Ash mentioned. So whether it's access, it helps them in terms of what they might want to do in terms of implementing a modern general practice offer. If it's around looking at clinical outcomes, it's about, again, making sure that how do we target the support that we offer and engagement with the population to help them kind of improve their health outcomes. And then what is it we might want to do in terms of adoption of digital tools and how we support the infrastructure that's needed around workforce, workplace culture, many other interventions and support they offer. So we're trying to get that really good learning that we've got within some of the innovators that we've got across Kent and Medway and scale and bring that into the practices that we've targeted as needing some additional support. And we've got a case study that's included in the pack as well, which I'll, like I said, it's so Courtview Surgery in Rochester. They had support from a peer ambassador program, and then they've been able to implement what we call a modern general practice offer. And in the pack, we've just, in terms of actually tracking some of the improvements that they made. So we've got a friends and family test that they complete on a monthly basis, and they went from a 69% approval rating in March to an 80% approval rating in June. And then we've also captured some of the patients' feedback in terms of what it's meant for them in terms of being able to access the surgery. And we have got some other examples that we're trying to collect case studies for, which really show some of the benefits and improvements that this approach takes. The other thing I just wanted to mention as well was around the role of community pharmacy. So I know we spoke about this at the previous meeting as well, is that we've got a number of community pharmacies that offer what we call pharmacy first services. So they support with some of the common conditions that patients can present into community pharmacy services. We've got a blood pressure check service and an oral contraception service. So what we've been trying to do over the past year is really just to try and make that awareness out there for the public that these services are available to them. We've seen a real big increase in a number of patients that are using these services now, and that's a continuing trend that we've seen. So we've just got some stats in there in terms of a Kent Medway position and what it was for the latest month that we've got the information for as well. We're working with a local pharmacy and general practice working together to enhance pathways, and I think actually one of the things that we spoke about at the last Health and Wellbeing Board is what can we all do collectively to help raise awareness of the opportunity that's there for the population to be able to access services from community pharmacy and help ease pressure on the system, but also improve access for patients. I'm just going to go and talk about Neighbourhood Health, and I think I'm just going to pass over to Ash, who's just going to talk through some of the concepts and what it might mean in terms of the way that we start to move some of what we're doing now. And actually one of the core components of this is having a modern general practice offer. So some of the stuff that we talked about in terms of what we're trying to do with general practice is one part of this, and then actually now how this kind of translates into trying to bring it together into Neighbourhood Health offer is what Ash will speak to.
Thank you, sir. I think Councillor Murray, you said about the neighbourhood. I'll try and explain in brief about that. I think the neighbourhood guidance which has come out talks about 6 critical elements to that. First one of them is the population health management. So what does that actually mean? Is in terms of we need to understand the data and what's the data telling us in terms of where are our challenges with our populations, what can we do to address them. So that's what population health management is all about. So we need to understand that as a part of neighbourhood. Second, Suk was just mentioning about the modern general practice. So for example, in terms of the online consultations, the access to general practice and cloud telephony and pharmacy first, how do we maximize that in our neighborhoods? The third and critical part also is the standardization of our community services. So if Ash is living in Medway, he should have a same offer of community services if Ash is living in Thanet. Yes, there will be certain nuances, but we need to have a standard community offer on everywhere across Kent and Medway. Another important element in neighbourhood health is multidisciplinary teams, whether that's for frailty, whether that's for children with complex needs, whether that's for mental health. How do you bring people from different backgrounds, whether they are from social services, they are from health, they are from mental health teams, anywhere, any of our groups, how do you bring them together to make this work? You would also notice is that a lot of our patients who especially frail elderly patients, when they get into the hospital, it's so hard to get them out. And the more they stay in, the harder it becomes. That's why they tend to get more unwell as they're staying in the hospital. So we need to have an integrated intermediate care approach in which we try and get these patients back into their own homes, because that's the best place for them. So that is going to be one of the 6 pillars of the neighbourhood health way of working. And I always say is, why do you let those patients go into the hospital in the first place if that's not the right place for them? How do you bring services together, especially what we call as an urgent community response services? How do you make them more effective so that they can provide that level, some of that level of care, which we can give them in their own homes, in their own care homes, and our own nursing homes? So these are 6 key pillars of how we get the neighbourhood health working well. Now, if we move to the next slide, I think some of the key important things which I want to bring out from the neighbourhood health design is focus on the patients. So when I said about the teams, we need to build teams of teams. But those teams have to remember one thing: they don't work for their badge. I could be working for Jonathan, I could be working for my own practice, I could be working for community services, but I don't work for my badge, I work for those patients. That's the key principle these teams need to have. We need to be data-led. We need to understand what our problems are. How do we tackle them, those problems then? And You all or somebody in your family would have faced this. You keep telling the history again and again. You see one of my colleagues, you have to tell the history. Then you go to another colleague of mine, you have to learn the history again. Why can't we have that one record system? And that's the key principle again in neighborhood health way of working. And honestly, we can't do this alone. As health, we can do a lot, but we need to work in partnership with you. We need to work in partnership with voluntary services to make this come to light. Otherwise, it will be a very hard if we try and do it on our part. If we move to the next slide, what are the benefits for providers? Way back in 2017, 2018, we set up a service which was sort of similar to what we are talking about today. And we call it the acute response team in Thanet. And the advantage of that service is that we have a waiting list in a place like Thanet where you can't find GPs to work. So if you do build something very innovative, you bring the talent in. And not only you bring the talent, you can hold on to that talent. And because what those people came to work for that service, a number of those GPs started working in our local practices. And that helps. Everything helps. And what this does is also it has an impact on A&Es. The worst thing you can have is your patients going into those corridors of the hospitals and getting stuck. Nothing hurts you more than seeing that frail 85-year or 90-year-old patient in a corridor in the hospital. If you do this way of working, it makes a difference. It really changes. It reduces the pressures on your GP practices also at the same time. Because of this way of working where we're supporting each other, it helps the morale of the staff. At this time in NHS, believe me, that's the rock bottom. We really need to do something like that to help staff. They need to feel that need to come to work. And this way of working, we have seen it, we've done it, so we know it works. And that's why it's very crucial we move ahead with this. And moving to the next slide, I think the benefits to the patient, I've been saying that while I've been talking about it in terms of I don't want to see any patient in a corridor. That's what really breaks my heart. That will be the most important thing if I can achieve that through this way of, we can achieve that, not I. We can achieve that. That will be the best thing ever. But also this builds on continuity. The people who tell me one thing is that if only my doctor knew me better, it would be so much good. About 10, 15 years ago, when I became a GP, I knew most of my patients like the back of my hand. We need to bring part of that culture back, at least for my frail elderly patients. They need to know those patients very well. And we're hoping by building teams like this, we can bring some part of that culture back like we used to have. So it's very important. And I keep saying that, telling the story once, it really, and from a patient safety perspective, if you have to tell your story again and again, there's a risk you might miss something. If you have patients' records in front of you, you can take some bold decisions which you might not be able to do before. So that's why it's so important to have those things. And we have shown that by this, you have improved outcomes. By working in a team way, by looking after those rising risks, those patients, you can get a better diabetic control, better hypertension control. If you do that, the risk of these patients deteriorating over a period of time gets better. So if we all know all of this, why aren't we working like this? So hopefully by doing something like this, we will make a difference on that. Now, I've been talking about population health a lot. I've been talking about population health management a lot. We're going to show you how does it look like in Kent and Medway. We're quite lucky in Kent and Medway that the teams like Malti and Mayur have gone out and actually procured something like this for us. This is something called a John Hopkins model. What it does is it risk stratifies. That means it tells us which cohort our patients are going into. So we start all the way from being a green patient at number 1, and that means the patient doesn't need much help, to all the way up to 11. And that's your most frail elderly patients. Some of those patients are in your care homes, in your nursing homes. And now, important thing for us was to understand where are our patients sitting. So if there are more patients in the green, what's the impact of that? If there are more patients in the red, what's the impact of that? So then we can design our services based on tackling this cohort of patients. So if we move to the next slide, this is what's very interesting. If you look at that red slot at the end, you would notice that the red patients is about 2.6 to 3% on an average. So it's about 10 is about 2.6 and 8 is about 0.4. So together it's about 3%. And what is interesting from 3%, if we go to the next slide, you can see that 3% has a 23% emergency admissions in the hospital. do remember one thing. This is the most frail elderly cohort of our patients. This is my mom. This is you. This could be your mom. So important thing is once they get into that hospital, it's so much harder to get them out. The length of stays of this cohort of population is the highest among any other population. So if we are able to do something right for this cohort, we have achieved a lot. And that's what our way of thinking is. I'm going to move to Sukh next, about talking about the accelerator program we have in Chatham here.
So the only thing I'll say about patient needs groups, the other thing we're rolling out is, and I've got it in my NHS app, and I'm a Medway resident, so I've got it in my practice, is that people can now see their P&G, so it tells them what number they are. And that's actually, we want to make it a common language across our health and care system. And again, people can use it in terms of when someone contacts them, they know actually the support that they need based on how they kind of rate on that P&G level. The other thing I mentioned is obviously we spoke a lot about the concept of what we're trying to do with Neighbourhood Health, but actually we're trying to actually put this into practice in some of the stuff that we're doing through some of the accelerator programs. And for the South East Accelerator program, we have the Chatham Central Neighbourhood Model, which David, through the public health team, has led, working with health, voluntary sector, other partners to try and drive forward what we can do, and particularly targeting the support. And particularly for Medway, it's about trying to look at the needs for that population. So there's some targeted support working in terms of complex physical mental health needs, and also looking at the wider determinants that we've got around homelessness, temporary accommodation, substance misuse and employment. So our primary care network are involved in it, public health are working together in it, social care and other partners. And we're trying to see actually how can we put this into practice using the James Williams Healthy Living Centre as an opportunity to try and use that to bring our partners together to better meet the needs of the population. So there is a really good opportunity for Medway in terms of how we can start to shape what we need to do around neighbourhood health. The only final bit I was going to mention is obviously there is a role for the Health and Wellbeing Board as well around how we start to develop our neighbourhood health plans. So I think, Councillor Murray, the point you mentioned about actually having that session is really helpful, and then we can think about how we work together and developing a plan for neighbourhood health for Medway. Thank you.
Absolutely, we'll do that, Sukh, and we'll take that as an action and work on that together. And early in the new year, try to put that in place because I think it's critical. So thank you very much, both of you, working backwards and quite quickly through the report, because I'm mindful that we've got the public health report to come as well. But it's really important to have this conversation. It's a while since you've been. Delighted about the accelerator programme, very grateful for the intervention and leadership that David has shown through this in a challenged population. I think what is standout is this focus on younger people who are economically inactive, who are not well, and who are very complex. And I think if we can demonstrate that the new model can wrap around those people as we're hoping and make a difference to their future, then we're making a difference to who's going to keep turning up at A&E and to that 3% of regular attendance well in advance of when it happens. And I think that has been a long time coming, and particularly for the Chatham Central population. So that is very welcome. Good news on the workforce. And I do think that people have become accustomed to not always expecting to see a GP and more readily accept that another practitioner can help them, and in fact can sometimes help them more because they're more specialised. Digitalisation seems to be working, and I think some of the mergers have helped with that. I do think we can do better for patients in explaining to them what is actually happening at their practice and through the expectations of digitalisation. I've had a number of people say to me they thought Amina was a person. It's a system. It sounds like a person, actually. And people get a text message saying, this text message is from Amina. And, actually, and I don't just mean elderly people, other people going, well, who's Amina then? I haven't seen anyone called Amina at the practice. So, that kind of thing is sort of an avoidable, a little bit funny misstep, but it does reduce people's confidence in what they're looking at and make them think that something has happened that they're not aware of. And, I've talked a lot about digital education. It's still a gap, and it's still something we need to work on, and hopefully Neighbourhood Health might give us an opportunity to do that, bringing in partners in the way that you suggest. It's good that some of the support we've put in has brought GPs here, and although the head count looks bigger than the number of full-time equivalents, it's, I accept, and I think other people should too, that GPs want to work flexibly and part-time like everybody else. And talking to the graduates, who I was very pleased to see when I went down to Canterbury, the first graduates from the Kent University Medical School, the Kent and Medway Medical School, 43% of them intend to stay in the area, and I think about 20% are going into general practice in one way or another. So it does show, actually, although it takes a long time, that being able to have that initiative is welcome. And I think there's a job for partners right across training to do, John, for you as well, in making general practice a bigger part of medical training. You know, more than a 6-week rotation to make it attractive. That came out of our task group. I don't think anything much has happened. And finally, I would say, thinking about what GPs say to us, is that when we're planning something like Neighbourhood Health as a system, we involve them. Don't plan it and then go and tell them that this is what we're going to do. You know, GPs generally are proactive deliverers. And I do think their voice gets crowded out sometimes when we're planning something on a neighbourhood basis. So with that, Eddie, you had your hand up. Jonathan, then Leanne, then Simon, please. Then Andrew, yeah, thank you.
Thank you. Sorry. I'm going first, yeah? Thank you, Chair. I'm very pleased to see this in place. I'm very positive about it. However, it's only going to work. Any solution to anything to do with social care and health, GPs, hospitals, whatever area it is only going to work if it's a part of a long-term plan and has cross-party support, because it needs to be long-term. And hopefully this won't ever get stopped just because of party politics. You know, they can't sign up to it because it's the other lot that introduced it. So I hope we don't get that, and we do get a buy-in. And the other buy-in we need is from all GP practices. So my first question is, how good has that buy-in been? I'm hoping that this approach will stop the very bad practice of some GPs sending people, in effect, indirectly sending people to an A&E. Over 5 years ago, when I worked in a care home with very, very vulnerable people that don't even have the capacity to express themselves, we could not only not get a GP to come in to the care home, couldn't get an appointment, and the number of times we therefore would take them to an A&E when they weren't emergency patients at all, but we weren't willing to take the chance. So I'm hoping that in itself will get stopped. So I'm just hoping that you can give me reassurances that you have got a long-term plan that is fully supported. And I want to give it a thumbs up because I think it's, in concept, a really great idea.
Thank you, Eddie. And before you answer, I'm going to take all the questions now and come back to you. So that one's about GP buy-in, because I do want to spend some time on the public health report. It is important. That's about GP buy-in to the whole system. Jonathan, please.
Thank you, Chair. It's a fantastic piece of work, and we've talked about it in the past, Ash, and this has got to be rolled out across the country just for primary care to survive and stand still. What worries me, though, about this is, and what I'm struggling to pull from the report, is we're still 60% light on the number of GPs in Medway. We need, just to bring us up to the English average, we'd need another 64, I think it is, GPs. Are we just building this on sand? That's what worries me around this, because if we haven't got enough GPs, how's this going to work? And what I'm struggling to pull out of the report is what actually are we doing to attract GPs to this area?
So, serious question there about Medway still being below average, which I think everybody accepts, Jonathan. It's important to ask. Leanne, please.
Yeah, really good paper, really good objectives. I can't see safeguarding in here. And we had a conversation in the beginning of this board about safeguarding. This is a really crucial thread to run through this, because I heard you say, Ash, quite a few times we can't do this without the partnership I can't safeguard the population without the partnership. So if there's opportunities for safeguarding to be writ large, that would be really beneficial. Thanks, Chair.
Thank you. Simon, please.
Yeah, thanks very much. Just to reiterate a couple of points, firstly, really like this. Obviously, it's got a lot of potential, and I think just to pick up on a couple of things. One is, I think Jonathan's already mentioned that point. I was asking, this is about change of approach and not needing more resources, or is it about more resources that are going to be needed regardless? And I think you've answered that point, really. We still need to get the resources in. So that point's been covered. I think the other issue that I'm not sure if I missed it or not, that mental health wasn't mentioned in there, but I'm sure you've got it in the process, but that's obviously going along with the safeguarding. That's just as much and often gets left behind. I think one of the key things, two other points, if I can, Teresa. One was about the, you mentioned a lot about bringing services together, about streamlined access and patient records and stuff like that. And it's a question that keeps coming up now in other areas which I'm working in, is about communication between the different elements of the health service. It is really poor. And how we overcome that, when I think it was mentioned the other day, 200 different computer systems at Medway Hospital, all not really talking to each other very well. Things like that are going to be a blocker for a lot of this, and how we overcome that. And I'm sure the GP practices are just as much aware of that issue, but that needs to be part of the process in terms of that. And the other point I was going to make was around how, I mean, obviously the outcome we're looking at, I see the Marmot fingerprint all over this, which is fantastic to see. But one of the other approaches, this is about less people needing care. That's the whole point about what we're trying to do here, and how that then connects to the areas which I cover within my portfolio is our place agenda for Medway, and how we deliver the parts of the active travel and all that sort of thing, making sure that that is very much embedded in all the other work we're trying to do as a council as well. So that's my point. Thanks, Teresa.
Yep. Andrew, please.
Thanks, Chair. The NHS is the most initiative-heavy organisation in the country, and I'm sorry, I'm going to be really cynical here. I'll believe it when I actually see it being delivered. Is the James Williams Healthy Living Centre actually open yet? Wow. I mean, that's got to be the longest gestation of a living centre, healthy living centre forever. I mean, I was just looking at news reports from 2024, and it's still not open. I was just wondering what the plan is for so we've got this new accelerator programme, but how's that actually going to happen in real life? Are we going to put the right funding in place to make sure we have this wraparound care, or are we just going to end up with a healthy living centre, everyone working in silos? You know, what is the plan? What's the council's involvement in making sure that that plan actually gets delivered? I was wondering how we're going to reduce the need for those in your red blocks. They apparently are taking up 23% of all emergency emissions. So what is the plan to reduce that? I totally get focusing on younger people, the younger end of the population, for lots and lots of reasons, but that group there is still consuming a lot of resources. And just finally, in terms of GP recruitment, I don't know if anyone else was surprised by the number of admin staff compared to the number of medical staff. Maybe we need all those admin staff because of the rubbish computer systems that we've got in the NHS. But I'm just wondering how productivity is going. Are we actually seeing more patients? And whilst I accept, Chair, what you said about the people are more willing to take a call from a GP, actually a lot of people need to see their GP. And it is still the most difficult thing in the world is to get to see a GP. And just in terms of the fragmentation of these services, I think you know, I myself get the odd email or text message from some random number saying I need to go have a blood test to go to a surgery that I've never been to and I don't associate with my own surgery. You know, that element of communication is something that desperately needs to be worked on. Thank you, Chair.
Thank you. I'm going to bring David in before Suk and Ash come back. And just to respond quickly, Andrew, to something that you said about James William Health Centre, yes, it took a long time for the funding to be agreed and assembled, but actually out of the ground and the build has not been all that long. It'll be open in the spring. There's been an issue with the roof, and we want it to be as absolutely good as it can be when it does open. So
Thanks. So I'll keep my comment very brief, and sort of it pulls together different bits and pieces that various people have said through the evening. So the guidance on neighbourhood health was published in January this year, and it talked about neighbourhood health service and neighbourhood health care. And this is a conversation we've had before. And then the 10-year plan talked about neighbourhood health sort of more broadly and talked about the role of the Health and Wellbeing Board in neighbourhood health plans. And what we're doing is we're working through how to come up with the way that we're going to deliver neighbourhood health in Kent and Medway. But some of the other comments that people have made, so Ash talked about the need to work in partnership. Councillor Curry talked about the role of the services that he's responsible for and how they can contribute. I think this sort of illustrates how important it is to have these good neighbourhood health plans coming through the Health and Wellbeing Board as described in the 10-year health plan, and how that we can use the different levers of the council, and different partners around the table here to help deliver neighbourhood health and help hopefully reduce the number of people who turn up at A&E.
Finally, from me, a quick question that needs answering. We really need access for adult social care to the same data that everyone else is using. We struggle with that, and it would certainly make discharges and other elements of our work much easier. So a lot to answer, and brevity being important, because you can come back to us if there's anything that you can't get through. Okay, thank you.
I'll give it my best shot, and then Ash may want to add a couple of bits in. But so in terms of buying from GPs, so this is, I mean, predominantly, I think there's obviously a big challenge around demand and capacity. And actually, this is one of the best ways that we're going to be able to try and manage the demand and capacity that we've got going into primary care through supporting these models. And we've got really good engagement that we do with general practice. Ash is obviously one of the Deputy Chief Medical Officer, has really good engagement with professionals working across Kent and Medway. And you might touch a bit more on that part of it. But we see general practice, and it is mentioned in one of the slides, as one of the core components of a neighbourhood health model. In terms of what we can do to increase GPs, and I think that's a fair challenge, I think, in terms of what we try and do and not take our off. I think it's about how we use this as an opportunity to create a much more attractive proposition that people want to come and work in. So the point you mentioned about actually we've got a lot more headcount but not enough as much full-time equivalents, it's because people want to work in a different way. They want to work a portfolio career, they want to work in different settings, and how can we use neighbourhood health as an opportunity to allow people to work in a different way than what they have done previously. And we've seen it before where Ash had mentioned you've got really innovative services. People want to come and work in those environments. So I think it's on us to create that innovation opportunity that people now want to come and work in that is slightly different to the offer that we've had historically. Safeguarding, I think exactly, we do need to bring that into and it is part of the work that we're doing. I appreciate it's not on the slides, but that is a core component, again, that we have to consider in terms of as we develop our services. The question about whether it's a change in approach or needing more resources, I think the slight challenge we've got to set ourselves is, are we delivering services in the most efficient way that we can be doing, or are there efficiencies that we can bring in the way that we do deliver services to the population? And I think that will be unpicked in terms of some of the way that we start to do and deliver some of this neighbourhood health model. We have got a neighbourhood health programme board which tries to bring together all system partners. So we have representation from mental health, community services, primary care, adult social care, public health. So we've got a broad representation that helps in terms of what we need to do around delivering some of this. A bit about the infrastructure. So some of the things that we do need to have a conversation about is what could we do across Kent and Medway that will help unpick what we've got around the shared care record. How can we get to a position that we agree this is what we can all have access to, the one shared care record, including what social care access and how they interface with the services that we use. What we want to obviously then get to is, I guess, the opportunity in terms of how we can get people getting the care that they need through the services that we deliver. The bit around estates, and we spoke about the James William Healthy Living Centre, I think it is not just about estates in terms of how we start. Estates is an enabler, but actually it is going to be about having that system-wide buy-in. This is the model that we need to go in, and all partners coming together to actually, we bring our resources into this. We can see the benefits in terms of some of the Ash had mentioned providers, and they then buy into what we want to do. But again, it's an enabler. James Williams Healthy Living Centre will be an enabler for people coming together and being able to deliver services to that population. For frailty, we mentioned about people that obviously we've recognised as a real challenge in terms of people going into A&E. It's about the proactive interventions that we put in place. And Ash, you might want to touch on that in a minute about some of the stuff that we are doing to try and put in that proactive intervention to stop people, because we recognise them, we understand who they are now, and we can make sure that we put some proactive support into them. in terms of actually, are we the productivity, and we're seeing, and we've had kind of information presented about GP appointment numbers, that is increasing. It is every year we're seeing more and more GP appointments being dealt with within primary care, but we recognise that that can't continue in the same way that it is continuing at the moment. So we do need to think about a different way that we can start to deliver services and how we can start to make the best use of things like community pharmacy and other providers that will be able to support as well. And then the other thing in terms of what Ash mentioned about the Johns Hopkins risk stratification tool is that we recognise, obviously, we do want more GPs. We would like to have more GPs in the system, but actually that does enable us to get people to be able to see the right clinician for their need and actually other people that will be able to support them where we don't have the GPs available in some areas. But again, those two people that do genuinely need to see a GP can get to see them through some of the tools that we've got. Ash, did you want to add anything else into the...
Thank you. I think Councillor Lawrence asked about the question about the focus we have. Actually, we're focusing on all the cohorts, but initially, Councillor Lawrence, our focus is going to be more on the cohort 10, 11, and housebound care home patients, because we know this is the most vulnerable cohort of our population. We really need to make sure we get it right for them, but that will also teach us how do we do it right for everybody else. And just to reassure, I think Councillor Curry had asked us the question about the mental health. It is one of our programs which we're developing for the neighborhood. So yes, that's one of the 6 pillars we have internally in terms of we need to make sure that we get it right for our patients with serious mental health illnesses, and we are able to give them the wraparound support as we need to, as we said earlier. Councillor Curry, you also talked about the rising risk. What you said about is patients, their needs getting more and more over a period of time. What we define that as a rising risk. That means somebody who's diagnosed as a diabetic today then has a bit of problem with the diabetes, and then they have, God forbid, they have an amputation or something. We need to get that right, because otherwise this is the cohort which will tip into 10 and 11. So we need to make sure that whatever we do, the care we provide to them, we're trying to minimize the risk from going from cohort 4 to cohort 5 all the way to cohort 9. So this is another one of the programs which we have in the neighborhood way of working. So we're looking at everything, but we have to prioritize, as you said, where is the area which is the most vulnerable, most frail of our populations, whom do we target first, and then learn from it and very quickly follow up the rest of the programs with that.
I'll be really quick because I know you want to get to the front. I would view this strategically as a thing we want to create that we can invest in rather than investing in our current model, which doesn't quite give us the outcomes we want. So we can't solve all the problems we've got on how many GPs and Medway there are today, but if we build something we can invest in, potentially at the front of what's going on nationally, then we can be a place where people want to come and work. We have Kent and Medway as a whole, but we've described primary care in Medway, has a higher spend in the acute sector than the average in England. So we are at the extreme end of what people talk about when they say we need to rebalance the healthcare system towards primary and community care. So we need to do this as almost more than others. And then the final thing I would say is your forward planner does not have this coming back in the spring. I'd suggest, I'm afraid I've got to go, but I would suggest that on the forward planner, we come back in the spring and we talk about the plan, and we could get it adopted by the Health and Wellbeing Board if you're willing to give us the support, because I think if we can get it into a multi-agency place and have your support, it'd be really powerful. Thank you.
And I think we can absolutely agree that we can be flexible, and we just need to do the kind of building session before we bring it back here, but certainly happy to make sure the forward plan reflects what you've said. So I think, thank you very much. We recognise, of course, how difficult this is. So there's no question about that. Medway has come from a difficult place, and anybody coming to work here and staying around, for me, is a positive, notwithstanding what Jonathan has said, what Andrew has said about how far we are from where we would like to be. And I think this over-reliance by people and the whole system on the acute sector has got to change. There's no question about that, and this is an opportunity to be serious about it, which is why, notwithstanding what you said, Andrew, about those people who are appearing very frequently in the system, working on younger people in a very, very focused way is important, and doing that in our most challenged areas, because otherwise we'll never break the cycle. You know, those younger people will be the people who are complex and chaotic and in poor health now, will just be the people who start taking up the lion's share of whatever the acute's got to offer in the future. And you know, other things happening that accord with this, such as the Get Britain Working strategy, through which we have seen some funding, particularly for mental health, for people who, with support, can return to work and can start to fulfill their potential and improve their health through that route. So whatever we do with Neighbourhood Health, we've got to make sure that we are very focused on bringing together everything that's happening and apportioning, if you like, you know, targets and activity to all the different parts of the system. So I feel optimistic. And I think that, you know, people recognise their neighbourhood, and if they feel like their neighbourhood is the place where their healthcare can be delivered, even if it's in a surgery they're not used to going to, that will be a step forward. So thank you very much for everything today. And finally, the big event. So Jonathan, to you quickly, please, for what we're doing for the recommendations, and then finally on to the public health report. And I'm sorry that we're running a bit over time, but we did have some really important things to discuss this time that couldn't wait. Thank you.
Thanks, Chair. The board's asked to note the details in the presentation and discuss how support can be provided to strengthen areas of challenge.
Is that everybody happy with that? I think we've had some really good things and got a lot to come back to. So on to our last item before the work programme, and that is the first report that has been produced by David in his role as our Director of Public Health. An innovative and interesting element of health, the importance of sleep. Like his predecessor, James, I love the title, Waking Up to Sleep. A lot of science is now being apportioned to the way that sleep impacts on our well-being and our health. So over to you, David, for telling us about what's in the report, and we'll be looking forward to it going across the council in other ways as well as here.
Thank you. I'll keep this brief as we are short of time. So yes, each year Directors of Public Health are required to produce a report of any topic, on any topic they like, relating to the health of their population. And as Councillor Murray said, I have chosen the topic of sleep. Sleep itself, on the face of it, seems like a pretty simple thing that we all do every day. And it's very easy to underestimate the impact that it has on our health and well-being. When we were developing our joint local health and wellbeing strategy, we did some engagement work with adults and with adolescents in Medway. And in both bits of engagement work, a key theme that came through that we hadn't seen before was that sleep was an important factor that was affecting their health and wellbeing. So I resolved to do my report, to look into sleep in a little bit more detail. I then had a conversation with colleagues at Healthwatch, and as a result of that conversation, they then conducted a survey with residents in Medway to understand their observations about sleep. And I've included some of those findings in my report, and I believe the full report was published about a week ago. Is that correct? Okay, great. So there'll be more information that you can see if you look on the Healthwatch website. So this report looks at the role of sleep in health and well-being. There are lots of links to health and well-being in different ways, and those links are sort of bi-directional. So poor sleep can make health worse, but also poor health can then affect sleep. There are links to obesity, physical inactivity, alcohol consumption, smoking cessation, mental health, a whole range of different factors. And there are also links to the building blocks of health, so the broader things that affect health, such as education and employment. With poor sleep estimated to cost the UK economy about £40 billion, and that, sort of applying that to Medway, that's probably about £20 million a year of lost productivity in Medway due to poor sleep. There are some conditions that are very sort of clinical, need a clinical intervention, but there are lots of people that have low-level problems that can be improved just by making small changes in their lives. So I think there's a lot of opportunity for us in our public health and other services to have conversations with people about how they're living their lives and how that can impact on their sleep. There's some campaign work that we could do to help educate people and help them to have a better night's sleep and feel ready for the following day. Thank you.
Thank you very much, David. And I'm sure there are things in this report that lots of us would recognise. And I was really pleased when David chose this, because I do think it's an underestimated and undervalued part of the health and well-being spectrum, really. You know, there can be a kind of macho attitude towards sleep and rest that diminishes the importance of it. And I think we're in a position now where the science is supporting the way that sleep deprivation has an impact on all of us. And I think, you know, I've got some direct experience of this, having worked with young people, in changing, in my case, the pattern of the college day to accord with what is a real thing. You know, adolescents are not lazy, that their bodies are changing, and with it, their sleep patterns. And it's important to recognise that and to support them in making sure they don't get sleep deprived because we're running a schedule that mitigates against the way that the body works in that critical growing and changing metabolic period. And similarly towards the end of life, you know, what the report does is say we don't just accept that in later life sleep is somehow more difficult to achieve. There are different factors, but actually most of the factors can be overcome with help and support. And while sleep might be lighter, it isn't less needed, and the lack of it can have a real impact on brain function and therefore on the onset of dementia and other things. And I think one of the things when David and I were in the early part of this, when he was discussing his determination to put this report together, something else that we don't recognise or just accept too readily is that if you've got a young baby, a young child, the sleep patterns of the baby and the baby or the child affect everybody else in the household. And it is a time of change, and we do need to recognise that takes a bit of management, and for a period of time anyway, will change the way that people are able to operate. So there's many, many aspects of this and many more to come, but I think it's really welcome that we've got our public health report about this particular topic, and that we can weave it into lots of the other strategies that we've got for helping people improve their health and prevent poor health, so that it is actually quite a critical part of our prevention strategy. And one of the things that we've done towards that, of course, is try to shorten council meetings, but not this one. I've been completely unsuccessful in doing that today, but for good reasons, I would say that, wouldn't I? Anyway, Eddie, you had your hand up, and then Simon, please.
Well, thank you, Chair. You more or less said what I wanted to say about how I am so pleased that this is now being recognised. It is very personal to me. About 3 years ago, I was identified with severe apnea. So every night I have this sexy thing of wearing a mask. If I don't wear this to force my channel area open, it is possible that you can stop breathing, you can die. And it's the only way, I know that's a extreme case, but it is possible, and it's the only way to get quality sleep. Unfortunately, it's still not enough. What annoys me looking back is that before that was recognised, and that was in consequence of a cancelled operation, by the way, so that was one good thing about that, was that for years, I can look back now, 10, 15, 20 years or whatever, exactly the same symptoms, having gone to more than one different GP, including my local GP, and just dismissed. And also, it's very easy to be written off, oh, you're overweight. So I've spent my life, my weight to my height ratio, I'm officially obese, but it doesn't help if a GP just basically writes you off on that basis, because this was going on as well. And I'm glad to see that in the report it does make the link between fatigue and exercise. Actually, it's so easy for those people that don't suffer from this. They can sleep easily. You may not get it because it sounds like you're making excuses and you're just tired. I'm actually somebody who likes working out at the gym. I don't look for excuses not to exercise. But if you're severely fatigued, it's really hard to push yourself, whether it's the mental work of physical work. So I'm glad to see that that was recognised. Thank you, Chair.
Thank you very much.
Yeah, thanks very much, Teresa. And I mean, I'll keep this as brief as I can, but I can't avoid, there's a lot of puns involved here, so I do apologise. In fact, you've used them yourself. So first and foremost, obviously I can see the importance of this report and I'm really welcome. I was unaware of this data. I mean, that's a really nice piece of work. It's been a real eye-opener for me, seeing all this, apologies, this data on it. And I think, but one of the things, a couple of things in there, that one thing that's not, it is mentioned briefly, but screen time isn't really high on the list. And is that because it didn't come through in the data, or because I'm aware of it so often that you've got your eyes on that screen so many hours a day? I'm sure that must affect how you behave. So I'm just wondering about that as a specific area, maybe for something for the health determinants research to look at, possibly, I don't know. One thing just to let colleagues know is that we've been working on a project with the Campaign for the Protection of Rural England, who've got a very active group in our area, on the Dark Skies initiative, and looking at how the areas around our urban centres can be made darker. A lot of progress has been made with the new street lighting we have, which is much more focused on the ground and impacting on people's homes a lot less than it used to in the past. So that's good. But there's some work and research that's about to happen on there, just doing the bidding for the work at the moment in terms of grants and stuff. So light exposure in our streets. And that just takes me on to that place-based approach to things. You mentioned in the report about the poor housing and rough sleeping being a massive factor, and I think one of the factors that we need to take away is the reports that we're now doing, putting together on licensing and stuff like that in terms of people's rented accommodation and stuff like that. Perhaps that needs to be a factor that needs to be built in. And one issue in particular that's been in the press a number of times is the availability to quality bedding and beds. There are children who haven't got beds and are sleeping on couches. I know a number of families in my ward where that's the case. Poor mattresses, all that kind of stuff is going to be a factor in there, and that's something that we need to build into the... Generally, poor housing is mentioned, but I'm just thinking about this crisis around availability of decent beds is really important. And the other thing that's missing, which I am a great advocate of, is perhaps it's my age, I suspect it is, and also the long meetings we have every 3 or 4 nights a week sometimes with meetings, is that daytime nap. And I find that a huge plus for me. I do, whenever the chance allows, with work and council work and my day work and all the other things in life, if that time allows just after lunch, I will go and spend 20 minutes not doing anything. And usually I'm out like within about 2 minutes, and then I set my little alarm and it wakes me up. And I feel loads better as a result. So I think I mentioned about daytime napping. If you can do it, go for it. Particularly for new mums and dads as well. I mean, that's important too. So there you go. Thank you.
I support daytime napping.
First of all, to second what Councillor Carey said on daytime napping, in terms of this report, it's a really interesting way of presenting it. I wanted to focus particularly on pages 8, 9 and 10, 154, 155, 156 across the age groups, because clearly what lies behind this report is issues like mental health. It's about support from people transitioning, the very things which we've been talking about today in terms of age. You know, the sort of young people's services finish at 25 for those with special educational needs. We've then got the sort of gap, and I was very interested in the previous report in terms of this, the gap between about 25 and 45, and then this report here that's in front of us now goes on to talk about older people. But I think what I really wanted to say is it's important that the council services support people across the age groups. There's a bit in here about rough sleeping, as Councillor Carey has already alluded to, and a number of people in that 25 to 45 age group are probably in that category as well, with homelessness issues and so on. So it's about what support we can give, not only across the council, but in liaison with government departments and, of course, the NHS. I've often spoken here about the importance of adult education, about the importance of skills training. You know, it doesn't just stop at school and with young people and further education colleges. It should go on throughout life. And all these issues need to come together really to support people with mental health conditions and with issues of sleep, the effect on the economy. Quite right that the director the public health director highlights that. Thank you.
Thank you. I can see we're going to have an amendment to the employment rights bill that all employees should get a half an hour sleep break on their employees. As someone who survived on 6 hours sleep for about the last 30 years, I was just wondering, David, I don't think I learned anything reading. I thought pretty much it's what you expected. But my question to you is, what are we going to do with this? Now you've produced this piece of work, what are we going to do? You know, for me, a lot of what's in here is about individuals taking accountability for their own health. Again, you know, I don't think the council or the health service can solve every problem. And, you know, maybe this goes back to good parenting, so children, you know, we talked about embedded behaviours earlier. You know, I've struggled with one of my children about getting him to get to a place where he gets a good night's sleep. I agree with Simon about screen time. I think screen time is an absolute killer. I mean, I'm sure all of us have sat there scrolling, looked up, and it's like 1 o'clock in the morning. You know, where's that time gone? And I'm a real advocate. I think I really like what they've done in Australia, which is ban social media for under 16-year-olds. And I do think that is a big root cause of a lot of mental health issues and poor health amongst our young people. But I'd be really interested to know what you're going to do with this report next. Thanks, Chair.
Just a light-hearted comment, Chair. Officers, of course, wouldn't know anything about daytime naps, and it's not really something I wish to promote.
Okay.
Okay, so thank you all very much for your comments. I think most were comments rather than questions, except for Councillor Lawrence. So what are we going to do? Very good question, very important question. There are lots of things that we can do that won't cost either any money or will cost very small amounts of money. There's lots of stuff, there'll be lots of opportunities for us to build things into our existing public health programs, for example, where we can just have conversations, when we're having these conversations with people about quitting smoking, we can just ask a few additional questions about how they're sleeping, give them information about how quitting smoking will help them to sleep better, and how sleeping poorly is making it harder for them to quit smoking. We can have those sorts of conversations, and the same with a number of other of the interventions that we deliver. We'll be doing a bit of campaign work. There are lots of quite simple things that people can change in their lives to improve their sleep. Full disclosure, another reason that I've done this report is because I myself was not sleeping at all well, and I was feeling exhausted. So I started reading around the topic for my own benefit and learnt a few things, some very simple things that helped me change the way that I was doing things in my life, and now I sleep a lot better as a result, and I feel a lot better. So I think there are some quite basic things, some myths that we can bust. So the 8 hours sleep a night is a myth. So people who only get 7 hours of sleep start to get anxious because they're not getting the full 8 hours of sleep. Adults need between 7 and 9, it's variable. Issues around smartwatches and people getting anxious about the amount of REM sleep they're getting. Smartwatches are not accurate enough to give you proper measures of REM sleep, they're just estimates, so people are unnecessarily making themselves anxious. So lots of simple things that we can do to help people understand sleep better and help them to improve the sleep. Oh, another one is sleep pressure. This is something that I discovered that I hadn't heard about before. Some people, if they're not sleeping well enough, will then go to bed early, trying to get more sleep. They end up lying in bed for several hours, not being able to sleep, and then get anxious about it, and therefore stay awake for longer. So it can be better to actually stay up later and make you sort of really, really tired, so that when you go to bed, you then sleep fully through the night. So there are small changes like that people can make. So there'll be a range of things that we'll be hoping to do over the next probably year or two. It's like many things we do in public health. Behaviour change takes time, but But hopefully just by doing this, we can make some improvement to hopefully a large number of people.
Thank you very much, David, and thank you, everybody. And I think you're right, Andrew. I'm going to put that to the government. A NAP built into the Employment Rights Bill. It'll do everybody a lot of good. And
They do it in the law, so.
yeah, that's and introduce some, obviously with our refurbishment of Gun Wharf, introduce some very comfortable furniture. We'll be doing that straight away. Anyway, I think it is, well, council taxpayers are people who work in Medway as well, so they'll enjoy it. And when you said you've survived on 6 hours, I knew there was something, so that might be what the issue is. Anyway, this is an important topic. It's in draft form at the moment. The full report will be published and we'll be putting it wherever we need to, and again, weaving it into all of the public health information and support that we give to people. And I think, Simon, what you said about what we can do for the environment, making things quieter, making things darker, all of these things contribute to people having a peaceful sleep. Well, I must say, if I go somewhere that's much darker and quieter than, where I'm used to being, that often keeps me awake, oddly enough. It keeps me awake. So, but I quite agree about the dark skies, because that's another lovely element of nature that we can all enjoy if we work on it, isn't it? Anyway, thank you very much for the report, David. We'll look forward to it being in its completed form and the impact that it makes on public health. Over to you, Jonathan, please.
Thanks, Chair. We've been asked to note the report and consider how each organisation that we represent can contribute to informing upcoming work as a result of the initial findings.
Thank you very much. Is that agreed, everybody? Agreed. Okay, and so our last item, Stephanie, please, the work programme. And I think we've already agreed that we'll work with partners to make sure that we get the training session in and put Neighbourhood Health onto the agenda for the early spring, absolutely.
Yeah, I mean, I don't really have anything to add. I am happy to take any comments. The only thing that I will say is the next meeting looks... I think we just need to discuss some of the items that are on there, because some of them may need to slip to another meeting.
No, that's fine. And I think some of the things that are on there are associated with other things that we're doing that have taken a bit longer, haven't they? So that's fine. And obviously, for people's comfort, we do have detailed pre-agendas with all of our partners, so we can work that through. Okay, Jonathan, for the work programme, please.
Yep, just to agree the work programme, please.
Thank you, and thank you to Jonathan. I think he's done a good job in being Vice Chair for the... That's it, so you settled into it very well and managed some challenging questions as well, which is exactly what we want for the Health and Wellbeing Board. So thank you very much. If the work programme's agreed, thank you very much for your attendance. Sorry it was a bit of a longer meeting, but I think we had some really important things to discuss this time, so thank you for coming.
Thank you.